Welcome. I'm Dr. Vinay Prasad. I'm a hematologist-oncologist, and I'm Associate Professor of Medicine at the University of California, San Francisco. In my professional life, I see patients, I teach trainees, and I do research in healthcare policy. This is Plenary Session. Plenary Session is a podcast at the intersection of medicine, oncology, and health policy, and you're listening to Season 3. On this week's episode. This week on Plenary Session, I have Atle Fretheim. He is on the forefront of thinking when it comes to schools, and he's from Norway, where they're doing something quite interesting. Next, I have Professor of Oncology Anthony Letai, Tony Letai from Dana Farber Cancer Center. He's a spectacular physician scientist, and you won't want to miss this far-ranging discussion on all things biology and cancer biology. You won't want to miss it. If you like this podcast and want more content, follow me on Twitter at vprasadmdmph. Check out the YouTube channel, Vinay Prasad, MD-MPH. Patreon backers will get access to the slides for lectures I give on Plenary Session. Want to hear from us? Email us your question at plenarysessionpodcast@gmail.com. I'm back in Plenary Session, joined via Zoom by Dr. Atle Fretheim. Dr. Fretheim is from Norway. He is a practicing public health expert and epidemiologist, and he works in the university in Oslo. Dr. Fretheim, it's a pleasure to have you here.
Thank you very much.
Now, I didn't get all your titles right, so what is your title? You tell me again. Tell me the right way.
My main job is at the Norwegian Institute of Public Health, where I'm a research director, and then I'm a adjunct professor at the Oslo Metropolitan University.
Wonderful. And your background is in public health?
Yeah, mostly, or more research, actually. I'm a medical doctor by training, but I've mainly been doing research and systematic review stuff and that sort of thing for the last 20 years or so.
Wonderful. So I'm really delighted that you can join us because, over the last few weeks on this little podcast, Plenary Session, we've been talking a lot about schools and COVID-19. And I guess there's a lot of debate going on, particularly in the United States. Some countries, particularly in Europe, have already reopened public schools. In the U.S., we're largely shut down in public schools. Meanwhile, private schools, daycares, those sorts of for-profit entities, they're running. They're running because they're making money. So really, it's sort of a entirely segregated system of people who are wealthy enough to go to private school or poor enough to go to public school. And I think there are clear downsides to the course we're on, and we're certainly not generating any evidence to understand any better. So, you were brought to my attention because you're someone who says, I don't know all the answers, so let's put this to the test. I wonder if you might walk us through, maybe first broadly, your thinking about schools, where they fall in this broader space of COVID-19, and then maybe what you're working on. The schools were interesting at a very early stage. I remember when we were sensing that something was going to happen in Norway, early March, that everybody started talking about what will happen with the schools. Will they close? I guess people started to predict that would happen because I don't think, the Chinese had, of course, closed their schools already in January, February. So we knew that might be coming. And so we realized very early that would be a big contentious issue. And I remember I suggested actually quite early in March, maybe we should think about randomizing. And that was in an internal meeting at the institute where I work. And as I expected, and which was fair enough, that was more or less laughed off as a sort of something that wouldn't be able to happen in practice. But then the schools closed down more or less overnight, as in most other places, and it became a big issue. Also at that point in time when we had the sort of close down, because there was a strong push from the public to close the schools. Sure.
Some of the mayors around the country starting closing the schools, and in the end, the national government didn't have much of a choice. So they were partly pushed, but they would have closed down soon anyway. But they closed down, I guess, a day or two earlier than they would have, simply because of public pressure. So at that time, there was very strong push from the public to get those schools closed and the kids home safe, so to speak.
And when was this? This was in March or April?
Yeah, mid-March.
Mid-March. And what about now? Are schools in person now?
Yep, they're back in full swing. So, and that happened in Norway. We were one of the countries that opened again first. There were along with the other Scandinavian countries, we didn't have a long closing times. They were closed 5, 6, 7 weeks, and then they opened. And we of course had pretty well functioning, I think most people would say, online learning during that time, which I guess is an interesting difference between the US and our situation, because the argument that you have, I've heard your podcast where you describe the tragedy of, kids sitting around Burger King to use their Wi-Fi to get their lessons. I mean, okay. I mean, it's clear that a lot of kids didn't have a good time at home, and didn't have the best circumstances to learn, but we didn't have that situation.
Right.
So,
Right. Norway at baseline is more egalitarian than the United States. So you don't have the extremes of poverty and maybe even the extremes of wealth that we do. If anything, that means public school is even more important here than it is there. I mean, you have more ladders of opportunity than we do.
I agree. I think that's pretty uncontroversial to think that way. Yeah.
So now that schools are in person, there is an upswing in cases in Norway. Are there calls to close schools yet again?
Not very strong, actually. So when the schools, that relates to the randomized trial you asked about that we planned, because our idea was, okay, the schools are now closed. This is back in March. Then we knew that at some stage the schools would have to reopen. They couldn't be closed forever. And then we suggested a randomized trial of reopening, and that's, I guess, what you heard about, because that came quite far.
Yes.
We actually got support all the way up to the top of the Ministry of Health. Minister of Health himself was very, very supportive of that idea.
Yes.
But in the end, the government gave the thumb down for the idea, basically saying that, and this was in late April, they said that we don't think we have public support for this, so we won't take the political risk, I guess you could, well, they didn't use those words, but that's basically what they said. And they might have been right. I'm not sure if the public was ready, because the wind changed. That was very fascinating how quickly the wind changed from more or less everybody or a lot of people pushing for closed schools. And then after like 3 or 4 weeks, everybody, so to speak, was demanding opening schools again.
I see.
And of course, this was obviously partly related to we had very low rates of infection in Norway compared to other places.
Yes.
And now it's sorry for taking so time to answer your question, but then we got so now you're right. There have been increasing rates the last weeks. Most people wouldn't say dramatic. I have not noticed calls for closed schools, but I think they will come. I've seen some. There is more and more push for more means. There is more aggressive infection control in the cities where you have the outbreaks. And there's been talk about, might the schools be closed again? But there's a very high threshold for that in this country. And I think that's a particularity with the Scandinavian countries, perhaps, where this idea of children's right to go to school is very, very strongly rooted. And it has a very, very strong support. And it's much more explicitly in competition with the infection control sort of aspect. So those values are really on the table opposing each other. It's not like just one or the other.
Now, people in the United States have pushed back on some of the episodes I've done, and they said things like, is it really going to hurt kids to be out of school for a year or two? What's the big deal? They can just sit at home on the couch, and they can go back in a year or two. No biggie. What's the downside?
Well, that's funny, because I heard your last podcast about this theme, and I was going to push back the same way. But, of course, if you say a year or two, nobody, I think, well, it depends on how well the online schooling works. But, I mean, that's almost so obviously not good for the kids that I guess you don't need research. But if you talk about, having the kids at home for 3 months with a reasonable level of online learning. If you look at the data, you don't find much about the downsides. Recently, there was a commentary on this issue in Science just a few weeks ago, and I was very curious to see, what's the current state that they refer to in terms of the downside. This was a paper basically arguing, like you usually do on your podcast, being skeptical to keeping the schools closed. And there's not much. I mean, the data is weak, so it's more a commonsensical approach, I think, when you argue about the downsides. Some of it is obvious, I agree. But, we don't really know really, how big a toll this has on the health metrics, etc. And it's quite mixed, the stories you hear, or the small amount of data from here and there. So I still think, well, I have another bias. I've spent a lot of time preparing for this trial, so I would probably argue for some sort of we don't know, and we should have the trial.
No, yes, so, right. Yeah. No, I actually think that is the best solution. We can talk a little bit about this public idea, but but just to come back to the schools thing. When I look at the data, I think some of, obviously there's no perfect study that has ever shut down schools in a nation like this en blanc, for everybody, that doesn't exist. The closest data I extrapolate to is, we do have some real-time signals of, reports of child abuse. They're gone. They've vanished. Reports of sexual abuse, they've vanished. And one would think that child and sexual abuse, they don't stop with COVID. COVID-19 doesn't go and stop child and sexual abuse somehow through its viral processes, that it is still going on. It's just unreported, which means more child and sex abuse. I also think that the best data probably is the data on caliber of teacher. There's a lot of economic data that says if you get a teacher that's in the top quartile versus the bottom quartile when you're a kindergartner, in sort of a random process of which teacher's class you get put in, 20 years later, you're making more money, you're more likely to graduate, you're less likely to have teen pregnancy, all these things. That's from just getting a better teacher than the bottom teacher. Now we're going from, average teacher to no teacher. I would imagine it's got to be bigger than that signal. If taking high-dose statin versus low-dose statin is a benefit, and you go statin versus no statin, I would imagine that's also not so good. So that's how I come to it. And also, I do think the burden of proof has to be on those who wish to shut down. They're saying that in addition to, all these measures we're taking, slowing our social movement, wearing masks, hand washing, all these things we're doing, closing bars, closing restaurants, minimizing work. If you can work from home, you work from home, you travel less, you visit people less, you fly less, all those things. On top of that, the last thing we're going to do as an intervention, on top of all that, is shut down the only ladder, the rotten ladder of opportunity in this country, because there's no other ladders. If you don't go to school, there's no ladder for poor kids in this country. There's nothing else. It's the school or, nothing. And they want to close that too. And so I think the burden is on them to show that there's a delta there, and I think they haven't shown it. But why don't we talk about? Go ahead.
I think I would probably agree with you, especially now that we know quite a bit more about the role that the kids play in the spread of the disease. I'm not sure if I would have agreed with you in March, when it was much more uncertain and we were much more worried about there were generally more anxiety about the risk related to COVID and the spread of it. So, but yeah, at this stage, fair enough. And that is actually the policy, I would say. What you asked, demand, is basically what we're doing in Norway right now. It's probably the last thing we would do is to close down the schools. It's really a high threshold.
So what do we know about kids spreading the virus? What do we know about their risk of dying? What do we know about that?
Yeah, right. So we learned, I think, quite early, based on Chinese data that have been replicated, I guess, is that kids seem to, it's quite clear that kids that are infected get much less severe disease, and they're probably also not as often infected, but that's less clear, I think. And what we really still are uncertain about is how big a risk an infected child is for their environment. But it seems the risk is pretty low, and especially after all the school reopenings, and we have seen relatively few outbreaks that can be linked to the opening of schools, and brought that contact tracing doesn't seem to show that kids play a central role. So I think there's definitely uncertainty, and I think most people would agree that surely a child can bring the virus home and can spread it to the family and to the grandparents and can cause death, but this is probably relatively rare. I think most people would agree on that now, although there is definitely uncertainty still.
What about teachers? Surely the child is infecting teachers in Norway left, right, and center, and teachers are suffering greatly. Is that true?
No, I don't think we can say that is true. We definitely don't have the data that I'm aware of that would substantiate that claim. And probably I'm not entirely sure what data we have. The data I've seen and heard about from Norway and other places is that there doesn't seem to be an overrepresentation. But there's so many problems with these studies. Contact tracing, it's not hard science. It's a lot of, it's difficult to draw firm conclusions from a contact tracing and exercise. So there's some problems with that, but it doesn't seem that we have a lot of teachers that have been infected in Norway or elsewhere.
Right. So, and that's a point I keep coming to, which is that everyone is talking about the data, and they find case series of one putative super spreader event. But the common fallacy in these super spreader events where the child is purportedly the super spreader is that there are other stories that could explain all those events. Like the adults have direct contact with themselves. They could have spread it between them. It doesn't necessarily depend on the child to be the spreader. And these are all kind of anecdotes. But we do have many countries are running school and they're not having massive outbreaks. That to me is more compelling data than these sort of anecdata of these case series. How do you feel?
Yeah, no, I agree totally. Absolutely. We've had, a couple of outbreaks here, and it seems that, even if you have 2 or 3 or 5 or 10 cases in a school over a week or two, that might just as well be a result of spreading outside school. It may have nothing to do. You might have had just as many cases with the school closed or even more. We just don't know that. And it's not even obvious or commonsensical that you can say that this is linked to a school just because it happens in a school like that. So, no, I would agree with that. And there is, it's the last time I looked it up, half of the children in the world are not going to school because they're closed due to COVID. Yeah. Which is, I think it's not necessarily a tragedy, although probably it is, or I guess you can at least be worried about that. But it shows that there is so much uncertainty. But there's a lot of kids, like you said, going to school, and they have been doing it for some months now, and it doesn't seem to cause an inferno of cases. Definitely not. And
I think that's the highest quality data that one could ask for. One has literally opened the gate on the dam and water is pouring into the river, and then you're asking, how do I know that dam's actually holding the water back up there? And you're like, well, it's just you've literally seen what happens. And in this case, we've opened the dam up and it didn't flood the villages. It didn't lead to all these things. We've allowed them to go to school.
Absolutely.
Let me ask you this. I actually agree with you that the step above this is randomized controlled trial. You talked a little bit about the public appetite, and that's something that guides, this is something that I keep coming back to where, in the United States, people blame some scientist and they said, this scientist paper is what led people to open up or led people to do this. This scientist paper led people to do that. And I was like, no, I don't think so. People are an unusual thing. It's this huge collective entity that's sucking in the media and giving it back to you. And so if you fill media reports with little kid went to school, got sick, grandma got sick and died, you tell that one anecdote on the media, show videos of the family, sentiment's going to change like that. It's just going to change on a dime. If you show a video of kids coming out of Norway school right now, laughing, playing, public sentiment's going to go the other way. It's going to go the other way. Public sentiment is a bellwether for what we put on the airwaves. We control the public sentiment. And then we say, the public doesn't want this. The public doesn't want a randomized trial because we have poisoned we've poisoned the equipoise. We told them it was bad, it was going to kill people. We told them it was good. So I think it's such an interesting thing. The public is, and the media, it's a rope with a noose on both ends. They control each other. And then we ask, why does the public have these beliefs? In your case, the public in both directions. On the shutdown way, you could have done randomization. On the opening way, you could have done randomization. In both cases, equipoise was lost. What are your thoughts on that?
Well, I think we could convince the decision makers in our case that there was equipoise, that there was sufficient uncertainty to warrant a trial. But the problem was, and I think that illustrates a common problem that you're alluding to, is how the public looks at things. I agree that the media, the way things are covered in the media, probably has a huge influence. But at the same time, we have a tendency to the polarization that you have, 100-fold more in the US.
Right.
But we have tendencies here, especially in social media, but you also see it in op-eds or commentaries in the papers, that you have the tendency of the group of people who are very concerned and thinks that the infection control should be much, much harder. And you have the opposite view.
Yes.
And this is it's interesting because when we propose then a randomized trial, both sides. I'm simplifying now.
Yeah, but you're right. Yeah, both sides.
Both sides are against it.
Yes.
Because they don't believe in equipoise, both, in separate ways,
yes.
which to me probably illustrates the whole point that we could, and oftentimes, you get the feeling that, people have made up their mind. It's like politics, right? If someone has, if a politician or a decision maker has made up his or her mind for good or bad reasons, a trial, I'm not sure. It's hard to say what difference it would make, and certainly they wouldn't be particularly interested in running a trial. And this is one of the barriers I find in getting these things done. And I'm not just talking about the elected policymakers, but also the whole bureaucracy
yes.
And parts of the public who have not economic but interest in a way in that this running a trial it's a nuisance. It interferes with daily running of things. Now we have an infection control. We have a situation. We have an pandemic, and getting research into that is quite. I find it quite challenging because people are running the system now in a good way and very consciously, doing a good job in controlling things. And a trial in the midst of that is It stand in the machinery, so to speak. It's interesting though. But I said I alluded to the public, which is not divided, but there's a tendency. But also in the bureaucracy, there is a tendency with a division. You have groups of people who are mainly concerned, partly from their from their heart, but also partly because it's their job to focus on the need for and the right of kids to go to school. And then you have others, those who are in charge of infection control, they have the opposite view. So you have that sort of polarization is too strong a word. You have that division within the government as well. So it's quite difficult to get support for first, okay, do we agree that there's equipoise that we don't know? And then, okay, so we should then perhaps run a trial. But we find it's very hard to get that sort of consensus around that idea.
Yeah, we're so skewed in the U.S. I've sort of lost this sense because in the U.S. there are all these powerful vested interests that say keep it closed, and then the places that say keep it open, that side is very weak because the people who really have an interest in keeping it open, they can find a school that's open for their kid. They move their kid out of their school. They take their kid out. And they take their kid out, then they don't care anymore. They lose that skin in the game. They lose that incentive. But let me say what I think the core problem here is. Whether you talk about politicians, who I think are abysmal, at the sense that politicians, a breed of people that thinks they know the answer to complex social problems without ever needing to study anything prospectively. Just a bunch of morons. You have to, I really have a low respect on both sides of the issue. They really are so sure that they alone know. You're talking about trillions of dollars of the economy and how to handle healthcare in the U.S., and everyone knows they have the answer. I have the perfect plan. You have to completely know nothing about science and history to be so cocksure you know the answer when you don't know anything. Okay, so that's the problem with politicians. And they're from disciplines where they don't learn this process. They don't know anything about science. They're very infrequently scientists, and they infrequently have the experience of science. The next problem, the public. The public knows nothing of randomized control trials. They've never been taught the randomized control trial. They don't know why it exists. The journalists don't cover it. The journalists themselves may not know it. There are few now that are finally learning it, but 20 years ago, they didn't really appreciate the importance of it. The journalists still cover the garbage, confounded time zero plague problem observational studies. They cover, berries improve your longevity and Finnish saunas are wonderful. They cover garbage studies. They're miseducating the public. The public knows nothing about it. And the education system in this country is so weak anyway, so nobody ever educated them in science in the first place, so they don't know anything about this. And I think even some intellectuals who enter this space from epidemiology or theoretical mathematical modeling backgrounds, they also have not been confronted by the challenge of empiricism, that everything you think can easily blow up in your face. So that's why there's a few of us, and many of us are often have some clinical background, and we know that you need randomized trials. Why do we know? Because we went in clinic, and for 10 years we did something, and our patients told us they felt better, and we felt good about doing it. We physically were doing it, and then randomized trial after randomized trial came out and showed we actually didn't help things and may have made things worse. We have that as in our gut. We've been gut punched by randomized trials. We've been gut punched, and we know that, oh my God, I thought that worked. It made perfect sense. It should have worked. It didn't work. And you get gut punched 20 times in your career, 30 times. And I've been gut punched more than most because I've done studies where we collect the gut punches. We've surveyed the literature to get some sense of how often these occur, and they occur with staggering frequency that everyone, and sometimes I read the study and I think, of course, this was going to be positive, and I get to the results and, oh my God, it was negative, really. So anyway, with that background, so teaching people the importance of randomized trials, we need to spiritually connect with them in some way to show them that things you believe, they can often be wrong. And if you really are an advocate, you commit to doing good and you let data guide the good and you let high quality data do the guiding. So back to this issue, I wonder if you might walk us through the randomized trial you proposed. How was it going to be done? Cluster? What's the sample size? What are the endpoints? What does it look like, the one you were proposing?
Yeah. So that's one of the big challenges is the last thing you mentioned there is the sample size. But yeah, let me walk you through it. That's where we really struggled was we realized how many students or pupils we would need. And yes, it was a cluster design that we opted for simply to avoid spillover effects, because you need groups of people who you will measure if you're going to measure spread of the disease or spread of the infection. And then another thing is that we aren't mainly interested in spread among kids, because that's not a big problem.
Exactly.
We're interested in spread into the community. So the first thought, obviously, was to measure spread, the rate in each cluster. And we thought about municipalities first. So we have 350 or so municipalities in Norway, and we thought about, okay, let's, we had the Minister of Health, and just a side point there, your speech, your negative speech about politicians.
Yes.
This guy actually understood the point.
Okay.
He said that he understood why we did a randomized trial. I'll give him that.
I see.
But anyway, so but then we realized that the rate of infection in Norway was far too low to be able to measure anything of value if we used the whole population as the denominator.
Yes.
Because that would make it, you would need so many infections. So that was a big problem. So we luckily in Norway we have quite good registries. So we plan to use routine data on registered infections. And what we opted for in the end was to use the proportion of tests among household members of pupils as the outcome, which is, far from perfect, but probably the best you could do when, in our judgment, when you weigh, all the downside and upside of different types of outcomes. So it's an attempt to measure the risk of spread from the school out in the community if you have open schools versus closed schools. And then, of course, along the lines of what we discussed before, we would also have lots of other outcomes that are not about the infection, about psychological health, about learning outcomes, etc. So that was the idea. But we ended up actually opting for, which was not the best thing, but we opted for randomizing schools instead of municipalities,
yes,
which increases the risk of, the clusters become smaller.
Yes.
So you have a high risk of spillover effects.
Yes.
But on the other hand, it was a power versus spillover effect trade-off.
Yes.
Yeah.
And
we would have wished to have all of Europe with us and do the same thing, but that was, but yeah.
And I mean, obviously, there's several keys here. One key, let's drill down a little bit on, is the endpoint for. I mean, there have to be multiple endpoints. You've nicely articulated that. They have to be endpoints for children well-being and COVID problem. These are the endpoints. Yes. COVID problem, it can't be sticking swabs in noses of low-risk people and finding PCR positivity. It just can't be that. Asymptomatic, low-risk people getting PCR positive, that's not the bad outcome. The bad outcome is people dying and people being hospitalized and having long-term sequelae. That's the bad outcome.
Absolutely.
Yes, go on.
But
yes. Yes.
No, I've heard you argue that on previous podcasts, and that's a point that you cannot be against, because the real outcomes, whether people are infected doesn't matter as such. we would I definitely agree. Nobody can disagree with that.
The lag, yeah.
But on the other hand, we have such a power problem with these studies that if you demand death by COVID as your outcome, I mean, I got to find another job, but there's no way that I can.
But I guess that's true in Norway, where cases were low. But in the United States, it's gangbusters. We have the power for it. We have all the power you need because we got tons of cases. We have rampant community spread.
Yeah. We did, of course, include those things as outcomes, but we didn't. Yes, I agree with you. I agree with you. We didn't expect to be able to show that. But yes, I totally agree. This is an important issue. But I think this is interesting. What outcome you should use to monitor the situation in the community and when you initiate measures. And that would be, in Norway, the current policy is to follow infection rates and use that as a guide. And you could argue we should wait for hospitalizations. But the worry here, of course, is that might be too late, that things get out of hand. The policy here is when things start to rise, bang, this is not my idea, and I'm not necessarily, against it or supporting it, but that's the policy we have, that we initiate quite strict measures when there's a local rise, in the hope to get control within a few weeks, so we can up again and have more normal lives. That's the concept. So we currently just look at the infection rates and not the clinical outcomes as a monitoring
and I think most places are doing that. I think it has challenges because not all infections are created equal, as we'll agree, and the risk of overreacting, and also the fact that the denominator is just constantly in flux, because what was what the course of the early epidemic is really a matter of mystery, because testing was so scant, especially in this country. So we really don't have a sense. And also country by country, I see all these country to country comparisons. They're not counting everything the same. They're not counting deaths the same. They're not counting hospitalizations the same. They're not counting cases the same. So it's very difficult to say Sweden is better than Norway, is better than Denmark, is worse than this, is that. I mean, we're not counting it the same. So how can we make these comparisons? What are your thoughts?
No, I totally agree. Except, we have to be pragmatic at the same time. If there's any point of doing comparisons, but I agree. My impression is that the usefulness of comparing improves the harder the endpoint becomes. So comparing the infection rate is useless because the testing frequency is totally different. So that doesn't make. But I guess COVID, or at least deaths as such, total deaths, that's probably comparable, but not very useful because you don't see the big changes usually. And then COVID deaths, I guess, is second best. But I agree. It's well known that is also registered in different ways. So it's a challenge to compare. Totally agree.
So your school randomized trial is where? It's on the back burner. It's not being done now. Schools are back in business.
Our main problem, one of the main problems with this trial is ethics regulation in our country. I didn't know this, and actually nobody else did, I think, either. But we got a new health research law a few years ago in Norway, and the wording of that is such that it actually probably makes this sort of trial illegal.
How's that?
Without informed consent from every individual who is affected. And I don't think regulation in other countries are like that. And I don't think most ethicists would demand that, but some would. But I think this is probably a glitch in the regulation in Norway. So what we're doing now is we're trying to clarify whether it's legal to run such a trial. Most people we speak to think that it should be, and that it's too bad if the regulation is worded clumsy in a way so that it's not allowed. Because you can do, of course, medical research without informed consent in certain cases, but it's quite tightly regulated in the law. And for this type of case that we're designing, there is no exception mentioned in the law, thus you can't do it. So that's our legal.
The irony is
right now. We're having
opening school and closing school affects lots of people who don't consent, But doing it in a staggered, randomized fashion so you can learn from it, that affects people who don't consent, so therefore that's illegal.
Absolutely. That's, I mean, we could speak about that, but we would be speaking to our own congregation. I totally agree. It's ironic that you can experiment without learning, but you cannot experiment with learning. That's, it's a tragedy. But yeah, that's the way it is. So but in parallel, we are working. So the idea now is we're trying to get a consensus or a support for the idea of having a plan ready, so that we can initiate a randomized trial of closing schools if the authorities think that now is the time to consider closing schools. So if the infection rates go that far up, that this actually comes on the agenda, we would like to have a plan there on the table already that everyone has more or less agreed to. Okay, now we push on the randomized button. But, we need to we're far from there yet, but I hope we can have the plan. I obviously don't hope that we will need to push the button, that the rates will stay low. But if infections rise, I really hope we can do the trial so we can learn something. I think it's a tragedy that it's such a mess all over the world. And I'm still almost shocked that there is no, that's not true. Very few other initiatives to do the same. I mean, this isn't rocket science at all. I mean, it's just very simple, but it's a huge logistical, political, etc. exercise. There are other people. There's a group in England who has prepared a protocol for something similar. I don't think they have succeeded in making it happen or becoming close like us, but they're a very similar approach. We had some communication, but there is very little happening. There's very little happening in terms of large scale infection control measures and trials.
Yes, I'm going to come to that. Yeah, but I think that
right.
If we reflect back on Europe during the years of the bubonic plague, the plague that rampaged it, came and went for centuries, really. I mean, there's many bouts of it. And most of the people, most of the civilizations, they did not even know the means by which it was spread. So many putative ideas came and went. Surely there were, I'm sure, some people who said that perhaps we could institute some rigorous ways to sort this out, figure out what's driving this, what's spreading. But people said that, we either have to do things or not do things. We wanted to do it, not to do it. Here we are, 2020. I think it's important to remember, we are not that different than the animal that dealt with the plague in medieval times. We're the same frail, person. We are barely more advanced than them. We know a few things more than them, but we could easily do these studies that would sort out tremendous things. We don't do those studies. 1,000 years from now, they'll look back on us and they'll say they knew about randomized trials and they never ran a single one. They're really primitive people back then. That's the way we look back at people on the medieval plagues, that they didn't even know how it was spread. And they did all these things that had nothing to do with it. And, and the way they look back on people from thousands of years ago who sacrifice goats when there's infections that spread. They think that's going to help. It's all the same, really, in my mind. An animal, a human being animal, who doesn't want to use the reason faculty and uses the emotion faculty. Is there any difference?
Well, no, I agree. But I guess to add to the complexity to your description of humankind nowadays, I'd say that to take COVID specifically, I think we can say that we know that keeping people apart reduces the spread of disease.
Yes.
That we know, and that makes it that's in a way also a barrier to research, because people sort of think that, okay, we know that, so let's just do that. Let's just keep people apart, and then things are, as much as we can. But of course, there are a lot. We've been touching upon all the failures of that way of thinking.
If we could put everyone in a separate room for 28 days, it will be gone. I think 28 days, everyone in a separate room, and so we know what will. Well, maybe longer, maybe a little bit longer, maybe 42, something, okay. Everyone.
No, everyone, yes.
Right, absolutely everyone in a separate room, some period of time, not that long, weeks, it will be gone forever. It will have done its thing. So we know what stops it. However, the arrogance of man is to think that the thing we're implementing is not putting everyone in a room and closing the door. We're implementing saying things like stay at home, closing the school, restricting grocery stores. The things we're implementing are 5 steps removed from actually putting everyone in their room. And the arrogance is that we know that those things have no countervailing effects and they don't do other things, and we know what must happen. That's, I think, the arrogance. Let's talk about other non-pharmacologic interventions. The pharmacology, we're good about that. We got a new drug, a new pill. We're good about doing randomized trials in those settings. Actually, not as good as we could have been. We could have been better, I think. We could have done more faster. We did a lot of wasteful observational studies. But non-pharmacologic interventions, what are we doing? What about the masks in Denmark? What's going on there?
Yeah, there are a couple. That's quite impressive. That's on the top of my mind. That's I'll have to brag about one study in Norway, though. In addition, there was a training center trial in Norway, which was quite early. It was before the summer. But yeah, the face mask trials, I think they're completed, with the results haven't been displayed, or we haven't heard what the results are yet. That'll be very interesting. I'm a little bit worried because they're individual randomized trials.
Yeah.
So that's the dilemma. I mean, you lose power with the cluster trial. I think they had almost 1 million people in one of those trials in Denmark. Well, one was in Denmark, the other was in Guinea. But with some Danish support, so maybe the same group, or I'm not sure if it's the same group, but the same sort of design. But what you lose then, if you don't have a cluster design, is you don't detect the effect of hindering spread from people. I mean, if you randomize people to wear a mask, you can measure the effect of not being getting the virus onto you. But I guess most people probably think that the main effect is hindering people from spreading it. And then you would need a cluster trial. So there is a risk that those RCTs from Denmark will show little or no effect, and that can be interpreted, in different ways, and potentially negatively if we believe that face masks have an effect. And I guess most people do believe, although we're very uncertain about the effect size in practice. But yeah, and then I must mention. Since I'm on your podcast, that we had this trial in Norway where we randomized individual members of gyms to be allowed to return, which was I'm allowed to brag because I had very small role in that trial, so I can't take any credit. But two interesting things with that trial. One is that it was a logistical really good stuff. Within a week or two, they had the whole system set up. They had testing. They had everything set up, and they ran the trial over 3 weeks. The problem was, again, the unpredictability of the pandemic and the power. There was one COVID-19 case among all the 4,000 participants in the trial over the weeks that it went. So it's very difficult to interpret. At least it was not, directly applicable to other circumstances. So that was the challenge. But it showed that it's possible, and was, I think, the first attempt. It doesn't matter if it was the first, but it was a real attempt to try to measure those types of interventions. But apart from that, trials, you mentioned the face masks and that study, and then there are a few attempts at the schools. Apart from that, I don't think there are some smaller, you can measure different types of masks in the hospital, etc. But those big population directed interventions, no, I don't think there's a single one. And that, if I may, that's something that interests me, being, a promoter like you of randomized trials for years. If we, in practice, cannot run randomized trials, what do we do? Of course, we don't give up. We keep pushing. But this is a sort of headache for me, because then we sort of keep pushing, or we give up, or we resort to what we would typically call weaker designs, and that's obviously a dilemma. But we're and I like to pitch, if I may, I'd like to tell you about what we're doing, and then you can thrash it if you wanna. But we were sort of depressed because we couldn't get this trial going, and then we realized that there's another contentious area. This was during the summer, when the universities were about to reopen. Now, you know this very well from the US. This is a very hot potato over there, isn't it? It was not that hot here, but it was an issue because the heads of the universities and the colleges were, the students are coming back in mid-August, 2 weeks from now. I discussed with them at the end of July or early August, some of them. What do we do? Do we keep it closed? Do we do in person? Do we do online? And I was not part of the discussion, but I heard that they had discussed this, and most of them ended with a hybrid solution. So they prioritized some students for in-person instruction, and some patients were prioritized for online. And then I thought,
just randomize that. Yeah.
We have to. Well, that wasn't possible. Okay. That was not practically possible. The law that I mentioned, it wouldn't be possible. So we opted for just doing a cohort
natural
or whatever you want to call it, study.
Sure.
And, exactly. So we have amazingly, we're not finished yet, but we have thousands and thousands of pieces of data on infection rate and instruction, and not in person, not in person. And it'll be very interesting to see what that shows. But how useful it will be for policymaking is, it's unclear. Obviously, if we get very, very convincing results one way or another, it might be helpful. And we are also including other outcomes, so we can compare, well-being and that sort of thing among students. But this is, we're spending it's not very resource demanding, but we're asking thousands of students to answer surveys online every 2 weeks for the whole semester.
Yeah, that's a great study. But let me touch on a few of these things. So let's talk about the gyms. I guess I'll just say, I applaud it. It was brilliant. The fact that the infection rate was so low has been used as a criticism. That's not a criticism. That's just the way it is. And if anything, it does show that it's safe to reopen if the infection rate is low. It's QED. Okay, but it was brilliant, and it would have worked brilliantly in our country, the United States, where we were knee deep in infections. We could have asked that question. The masks, there's such a tunnel vision on masks. There's so many other things people do and could do to slow the spread, from hygiene, such as the availability of hand sanitizers, plexiglass divisions in grocery stores, face shields. These can all be randomized, but we were just so obsessed with masks. And I think it's in part because the advocates, they somehow it was a mentally seductive idea. It's so seductive that if you cover your beak, you're not going to spill the virus everywhere. And it's a visible sign that you take it seriously. People don't wear it. They don't take it seriously. Look at them. They're not even wearing it. It's visible. It's a badge of courage. It's like wearing, that American flag pin in your lapel. It just shows that you really care. And so that's why I think it took off, and not necessarily that it had the strongest data. In fact, hand washing is much stronger data. And sometimes I'm walking around, it's a hell of a time to find enough sanitizer to put on my hands. Where is it? It's hiding. They should make that more available. Anyway, but back to your point. Why is it illegal in Norway, and why is no one running these trials? I think the root of it is the same root, which is people do not really understand why we need randomized trials. They think that these alternative forms of evidence, these sorts of retrospective comparisons that are going to come, I can imagine there's going to be as many retrospective comparison studies of COVID-19 as there are people infected with COVID-19. It's going to be, in the decades to come, it's going to be a slew. And if you want, you'll find whatever you want. I promise you. Schools were good. Opening schools was good. There'll be 10 retrospective studies that show that. Closing schools would have been better. 25 studies will show that. And in fact, the number of retrospective studies that will show what you want will be identical to the public perception of what should have been done. It's going to be just an opinion poll and a self-fulfilling prophecy. It's just going to be whatever you want it to be. People don't really get why we do randomized studies. They don't really understand. And too many people in the academy are in the business of doing the other studies. Their whole careers are doing the other studies. If they really believed in their gut that the fallibility of the other studies, the test characteristics of the other studies, the truth validity of the other studies, they wouldn't spend a career doing it. So they cannot believe that, What are your thoughts on this? This is really the core philosophical issue I think we struggle with in science and medicine, which is that the law is written in a way by people who don't know randomized trials, why they're done. That's why your law is the way it is, right?
Yeah, well, I'm not sure if that is the reason why the law, but it is the way it is. But it is definitely an important reason why it's so hard to get these trials done anyway, because we need a lot of political and public support to get those trials done. And I agree, there is the lack of understanding or interest or whatever on the usefulness of those. And I agree also that I also feel that there's a too low enthusiasm in academia for running these large scale trials that we need. And also I agree that we do not need the tsunami of retrospective studies that we can expect over the coming years. So we'll have like a modeling. Now we're in the
model
modeling
the papers,
phase,
the retrospective studies. Yeah,
the model. But so that is a pity. And but we're really struggling to find the key how to get this through. I'm feeling that there is a progression. I feel that there is more understanding, more interest. There is real debate in the public atmosphere or public sphere about these things. But I'm not sure.
Let me ask you this.
It's easy to understand that it's controversial or people get divided about a trial of school closure because it directly affects people. So I have to keep my child at home for a month extra for you to run this trial. But on the other hand, it's. I'll give you another example. Right now, there's some countries in Europe, they are changing their quarantine policy for children, for schools. So from what I hear, France has just implemented a policy where they don't bother with quarantining, or I don't even think they do contact tracing.
Yes, right.
They send the kid home, probably in isolation, and maybe they quarantine the family. I don't know the details. But for all other countries like Norway, we would quarantine the whole class or the cohort or the bubble or whatever you call it. Sometimes the whole school.
That should also be randomized. Absolutely. That should be randomized.
But I've suggested it, and
let me give you another example of some things people tell me. I'm a big proponent of randomized trials, and I would say there's really only two spaces where you don't need randomized trials. So one are that BMJ article on parachutes. You don't need a randomized trial for a parachute. But what is a parachute? If you jump out of airplane without parachute, 99.9999% risk of death in 5 minutes. If you jump out of plane with parachute, 99.999999 risk of living. Okay, that effect size. Get the fuck out of here. There's no effect size like that in medicine. That's the best effect size ever. That's the effect size of having a gun to your head, pull the trigger, no pull the trigger. That's the effect size. You can survive a gunshot wound to the head, but you're not gonna, most likely. Okay, that effect size, you don't need randomized trials. Do it one gunshot wound to the head, okay, this gun is gonna kill people. Okay, the other extreme is people who say, they use these as examples of why we can't do randomized trial for school opening. They say, we don't have a randomized trial of a parachute, ergo we can't do it here. And I'm like, and I wanna tell them, are you out of your mind? You think the effect size of school opening is 99.999% on 100% mortality rate on everybody in 10 minutes? No, it's not even close to that. It's gonna be a very marginal effect size, and so you need this to separate what's real from fake. The other way they screw it up, I hear, there was never a randomized trial of smoking. Well, I say, we don't do randomized trials to investigate putative harms. There's never a randomized trial that if I drink a glass of benzene, I'm going to be sick. Or a randomized trial if I eat poison or I get shot in the chest. There's no randomized trial that says if I jump off a building, I'm going to die. But we don't do things. We don't do randomized trials of putative harms. We do randomized trials of putative benefits. And in these cases, you are all saying, your claim is that school closure or opening, quarantining everybody or some people, you believe that is a putative benefit. The effect size, at best, is modest to marginal. You don't know if there's an effect over doing the alternative. And in those situations, there's only one thing that will answer the question, and that is randomization. And everything else will fall short. That is randomization is a hammer, and this is that nail. And we have to pound it. And so I think people, the fact that deans of public health schools have used these straw man arguments of parachutes and smoking to argue why we shouldn't do a randomized trial of vertebroplasty tells me that if the deans of public health schools don't know this, then the average person certainly doesn't know this, and they certainly are confused about randomization. But anyway, we could go on and on about this. I want to talk about a different topic, and that topic is this. You're in Norway. That is a Nordic country, and you're next to Finland, and you are next to Sweden, you're next to Denmark. People love comparing those four countries and deciding who is the failure and who is the success story. And I want to know, from your point of view, as a researcher in Norway, how do you judge Sweden? Did they do anything wrong, anything right? Did they make mistakes? Did they do anything smart? Can we learn anything from them?
I would be very careful to learn a lot from neither Norway nor Finland nor Sweden or anyone at this moment, because I think there's so many unknowns. I mean, clearly they have had a big tragedy in terms of the rate of deaths among old people in Sweden. I think we can say that's a fact. I mean, they've had several times as many dead, even if you obviously adjust for population size, as all the other neighboring countries. But why? I mean, that's the interesting question. What is the cause of this difference? And the popular sort of narrative is that it's because they didn't initiate as tough means as the other countries. They initiated sort of the same means, but there were more recommendations and not regulations. And that was the main difference. They said, please stay at home, keep distance, don't go to the bar, but they didn't forbid it like we did. And then people say that's the cause. It might be an important contributing factor. It might be a very, very big factor, but I'm not sure about that. And I don't think we have the data to say that this is obvious. They might have had the infection a couple of weeks before us, so it was sort of out of control before they can initiate these voluntary means. That's one theory. There are other theories out there, and it's mainly an issue about not being able to protect the
I think
and
that's
elderly.
the key. Right.
Yeah, but still, I mean,
proof ways to settle this will be someday. These cell phones are wonderful GPS trackers. We will have very detailed tracker information on Norway, Finland, and Sweden. And if it is revealed that actually the behavior, whether or not you had a mandate or whether or not you had a strong suggestion, if the behavior was more or less comparable, that would be one thing that erodes the sort of causal claim that it was the mandate that that was required. Right? Yeah.
And there have been some data along those lines comparing, for example, the rate at which Swedish citizens cross community lines compared to Norway. And I believe, and I'm on thin ice here, but I believe that also in the early phase in March, April, that they did have more movement than we had. But so there are some things that indicate that being a more tough at that time probably would have been a better approach, but this is very uncertain. I would be very skeptical to anyone who knows the answer to that.
And especially from the way in which we have to look at the data. Now, the other thing I wanted to ask you about was vaccines. It is possible that a vaccine is approved in the next, whatever period of time. It's possible that its efficacy is maybe 50%, maybe it's lower, 40%, 30%. It won't be given to everyone right away. We're still going to struggle with these decisions. So a vaccine entering in the world in November, how does it change your thinking on this issue? How does it change the need for randomized trials? What are you thinking about when you think about that? I've been thinking about that. How much time should we spend on doing randomized trial of infection control measures if we get a vaccine that stops the whole thing? But I think there's... Clearly, I would be courageous enough to say it's clearly uncertain how quickly an sufficiently effective vaccine will be in place to make these types of measures, infection control measures, unnecessary. We're still far from there, I think. So, and the opinions are so split. I mean, I'm not sure what the most optimistic estimate now is not to have a vaccine, that's one thing, but to have a vaccine that has been disseminated sufficiently to get, the don't say it. It's a taboo word. It's a taboo word. So I mean, it's probable that will take so much time still that we definitely need to know more about these the usefulness, both the downside and upsides of these more tough
infection control measures in my
Did the goalpost change in the pandemic? I remember the discussion in February and March where people said that when a pandemic spreads like this, spread is inevitable. It is inevitable that it will spread, and all we can do is flatten the curve, change the trajectory of the spread, but we have to allow the same cumulative number of cases will accrue over time. I mean, that was one leading theory. Somewhere along the way, the flatten the curve idea became the idea that with these measures, whack on and off switch, lockdown, school closure, these sorts of measures, we can eradicate the virus. Did it change, or was it always this strategy? What is the strategy, if one were to articulate it?
Yeah, well, I think it's, and this is where the two
Yes.
groups, the polarized group, interpret things differently. I think some would argue that at a very early stage, the idea was that we need to flatten the curve and then let it sort of burn through the population. But the wording typically was we need to achieve herd immunity. And implicitly or not, that meant either a vaccine or just, burn through the population. And that seems to have been a source of some of the polarization. I think, at least the little we see of it here in Norway, is that there's a lot of discussion. What was said in February? What did people actually mean? But right now, I don't think the policy, the idea now is to flatten the curve, keep it, down. When it starts to bump up, we keep it down, waiting for the vaccine.
That's the new strategy.
That's the whole.
So
I think
suppression till vaccine.
Yeah. And nobody. I don't think anybody. You're right. There were some people who thought that it would just go away if we just had a really tough.
Yeah.
Like you said, if we really close the borders 100% and
that's what New Zealand thinks. I think isn't that what New Zealand was doing? Yeah.
Yeah. Right, and we heard stories about Vietnam and some other countries who managed somehow, and of course China, where it was said that they did it without a vaccine. But some people seem to argue that way still. But the common thinking now is we're trying to keep control until the vaccine.
The problem with China is one. I mean, half the figures you can't trust. I mean, we don't know the true wave of the epidemic in China. And two, China is capable of instituting lockdown at a degree that we cannot institute in any free society. I believe for a while in China they set up central shelters and tents. And if people test positive, they were pulled out of their house and had to convalesce in that tent. You can't, it would be unthinkable to do that in this society. I think you couldn't even achieve it.
Yeah. Yeah, and they have such a central control that they can actually, actually close down the city and just bring in food from the outside and just, keep the city going with support just decided by the central government that they should just get food and water and stay closed for a month. And they almost did that, which is, practically, well, that's part of the debate. Some people would say that we could have done that. I've heard individuals claim that we could have done that in Norway. We could have closed the borders and just, shut down, but that would still mean, it doesn't add up in my mind. So, and not, like you say, not practical in a free society to do
now,
that.
The vaccine efficacy thresholds are, I was reading about it. I mean, they're good. 50% reduction, lower bound of the confidence interval, 30% or higher reduction. That's good. It's not terrific. It's not 70% reduction. It's not lower bound confidence interval 50% reduction. I guess one question I have is, even as you vaccinate, there'll still be outbreaks of the virus. Potentially even after everyone is vaccinated, there'll still be some outbreak in the future. Also, durability of the vaccine is unknown. Is that a possibility that we'll be facing recurrent vaccine outbreaks, or you believe the vaccine will really kind of neutralize the threat?
Well, in my naive thinking, I've been sort of expecting that once we get a vaccine that is considered effective enough to be distributed to the whole population, we must expect that will close the story as long as we get it delivered to everyone. But I guess if we have a sort of effective vaccine and that's all we have, I guess we will start using it just to as part of the flattening of the curve strategy. But I haven't thought about that. I've been thinking that once we get a sufficiently effective vaccine, and we get it spread out to the population, then it's a done deal. But you're right. That might not be the case. I guess
I'd say. I mean, I'm hoping your scenario is right. I think the challenges I see are, one, distribution is going to take a lot of time. months, perhaps a year.
Yeah.
Manufacture will take a long time. There'll be outbreaks then. And then the other possibility is, God forbid, that this is going to be a very quick vaccine. And the durability of the vaccine will be unknown. So maybe it protects you for 3 months, 6 months, enough for the trials to be positive, and maybe it has some waning efficacy. All sorts of possibilities. So anyway, I guess I think the reason I say that is not to be a fearmonger. I mean, I think it's something to consider, and it also does kind of suggest that doing these randomized studies, come what may still have a value. I mean, that knowledge may be still important to gather for future pandemics or for things to come in the years to come that we don't foresee.
Yeah, I think so. I think it's still worth pursuing them.
Dr. Fretheim, any last thoughts on this topic? I mean, I applaud you for your work. There are a lot of people who talk the randomized talk, but you walk the walk. You've pushed for it hard. You've done the tough power calculations. You've thought through the logistics. Thinking through sometimes very practically how to do it is very rewarding for thinking about, I think, how one thinks about the virus and how it spreads. When you really get into the weeds of how do you design the study, I often like to think about the specifics of a study, run some power calcs. Sometimes it gives me a better sort of philosophical view of a landscape to run a power calculation and think, and think about how you would study it, because it gives you a sense of the effect size you're chasing, what you will learn, what you might not learn. Any last thoughts about this space? I find it so interesting. I think 100 years from now we'll be better than we are today. I hope, just as we were better than 1,000 years ago.
One last thought, if I may, on that note, is I wish that we could learn from this pandemic and maybe also do something about it while it's still ongoing, is that we would benefit from having a preparedness, some sort of system that we can run these types of trials when the occasion arises. When there is a new epidemic or other types of outbreaks or crises, we have a system in place. The legal barriers are sorted out, the understanding among the decision makers, so we can rapidly institute trials and get them done, within all the ethical frameworks, etc. That's something I hope we can learn from this exercise, and we have an ambition of trying to achieve something of that sort.
I would say that I think if you work on drafting something like that, I would love to be a part of it. I mean, I think some of the principles that guide what I would be interested in it is I think there have to be two big sections of it. One will be pharmacologic and one will be non-pharmacologic. We cannot forget non-pharmacologic. We have to do cluster randomized trials so we get, especially for contagious diseases, so we get a sense of those externalities of spread. Many nations have to participate. Places with high event rate have to participate. The higher the event rate, the better, the faster we'll get the results. The faster they can be implemented, the less paperwork, the better. On the pharmacologic side, some principles I have is one of the great errors of this whole debate was in prioritizing what to study. The things to study first should be repurposed drugs that are already manufactured at multiple sites that have the same preclinical justification as novel drugs. In the U.S., it's all remdesivir and mamamimab. It's all novel drugs that are going to be really costly. But even if they work, how are you going to scale up the production and get it to everyone globally? The dexamethasone study from the UK is much better. Dexamethasone is more widely available. And then I think once the trials are positive, one of the big errors of the dexamethasone fiasco is people think dexamethasone good, give dexamethasone. They don't realize that if you're not on O2, it's not so good. So they don't know the nuances. So we need a way to, when the data is resulted, to distribute it in a high yield way where people are doing the right thing. Anticoagulation, we could have sorted that out. On the non-pharmacological side, so many things could have been tested. It was a failure of the imagination and a misunderstanding of randomization not to do more. And I think in the future, we should have a playbook. Whatever global catastrophe occurs, insofar as we can learn as we go and careful experiments, we ought to do it. I think that's the most pressing need that has arisen.
Yeah, a playbook. That's the word I was looking for. Thanks. Yes, that's what we need.
Dr. Fretheim, it's a pleasure to talk with you. You have to come back and give us some updates on this in the future.
Thanks a lot for having me. Thank you.
I'm joined here in plenary session via Zoom by Dr. Tony Letai. It's a real pleasure to have Dr. Letai, who is a professor of medicine at Dana Farber Cancer Center. He is well known to many people in cancer medicine and particularly on Twitter. He is an MD PhD from the University of Chicago, so we share our medical school alma mater. He went on to the Brigham and Women's Hospital where he did his internal medicine residency and then fellowship at Dana Farber Cancer Center. And he has been stuck there in Boston for quite a while now. Dr. Letai, it's a pleasure to have you here.
Yeah, it's a pleasure to be here. It's to be able to have a conversation with you. If it requires a podcast, that's the price I'm willing to pay.
Well, I guess I'd say if we were going to talk, I know it'll be great for my podcast because people will love to hear what you have to say on so many things. I mean, you're well known for being a physician scientist in the field, well known for being really a thoughtful critic, a well-respected critic of, I think, some of the philosophies in cancer medicine, which we're going to talk about. But, you are in a unique position because you're somebody who's really thoughtful and critical about the way we are marketing and hyping oncology. And you're also somebody with a foot in the lab who's thinking about how do we advance and innovate. So, you're doing a bit of both.
Yeah, I try to. I honestly don't know if, I guess I am critical of things, but I think part of me thinks that the appropriate poise of any scientist is skepticism.
Yes.
And that is whether it has to do with clinical data or physical data or whatever it is one is to take a Popperian view of the landscape. One is always trying to disprove hypotheses.
Yes.
And looking for weak points and looking for tests that will disprove a hypothesis. And that's the way I view an awful lot of things. And I think even very good scientists have sometimes an emotional response to people who embrace this a little too rigorously. One can embrace, there's no end of political issues where if you take that sort of point of view, does not make you a lot of friends, but I don't think there's all that many different ways of knowing. There's different levels of confidence in what you know, but I still, it's ingrained in me, I view most things with skepticism.
I think that's right. And I think that is, at the end of the day, that's just another way of saying you're a scientist at heart, I think. I think of them as synonyms. And so much of the response to some of hype or things that are spun is just your inner scientist comes out and says, oh, come on, you're going to have to give me a lot of proof for me to believe that.
Right. Exactly. And always, and also, I just love this. If I can just summarize what I understand of this point of view, it's just sort of the idea, you and I would both agree that copper conducts electricity, right? Sure. The classic example, right? However, it only takes one experiment where someone does an experiment tomorrow and the laws of physics change or whatever it is, and copper doesn't conduct electricity to have disproved that hypothesis. Even if there is 1 million experiments where it does, it only takes one to do. And it makes you really consider how difficult it is to obtain knowledge and truth. And what I'm surprised by, not at many levels, both at the basic science level, medical level, is not that people believe one thing or another. You have to. You're in medicine. You're faced with a patient. You have to make a decision.
Yes.
You have.
Yes.
Often, very, very often, in the face of very incomplete data and very inconclusive data. I understand you do that, but what I don't quite understand is the intense confidence, almost emotional confidence that you then have in your opinion to make a decision in the face of incomplete data is what we do with 99% of the decisions we make in our lives.
Yes.
Including the most important ones like who to marry, where to live, what career to pursue, and all that, right?
Right, yeah.
But what I don't get are the people who make these decisions and yet are 100% true, right. I don't mean, I accept my marriage from that. I'm 100% sure that my marriage is the right decision. But for all the other things in life, it's very hard to be 100% certain. I'm always struck by very intelligent people that are very certain about things when they couldn't when they'll take that same mind and apply it to a scientific problem and have this correct skepticism, but then and just move even a tiny bit off their area of expertise, and they're willing to evince total confidence in things that no one could possibly know.
That's so funny you say that. I agree with everything you said. I think that we forget often in times in life on a daily basis, we're making thousands of choices and decisions on a daily basis. The vast majority are we don't have any evidence. We're outside of the realm of evidence. And you're really talking about really the most important questions, who to spend your time with, where to live, when to have kids, things like that in life. There's very little evidence. But I'll give you one example of this kind of mindset, just sort of a microcosm. Many many years ago, I was interviewing, I think, for internal medicine residency at Stanford. And I forget who I was interviewing with, but one of the faculty members who's a big proponent of evidence-based medicine. This person really wants to have good evidence to do things. And in the course of the interview, this person pulled out a sheet of paper and they said, I'm just going to ask you a few questions. What are your strengths and your weaknesses? What was a difficult situation you felt and how did you overcome it? Sort of those classic questions. And I said, I'm happy to answer these questions, but I just want to tell you, I actually spent a few years ago, I looked into those questions and you're asking me those questions because you want to know, am I going to be a good resident here? And so that you really want to know about my job performance. And it turns out those questions, whether I answer them really well or really poorly, tells you almost nothing about how well I'll do the job. And he pushes his chair back and he says, you know what? I'm such a proponent of evidence-based medicine, but I never once thought to extend it into the interview. And that's similar to what you're saying, that people are good scientists in their little field, and then sometimes you go a little bit outside of their field and they forget their science hat.
Yeah, that's exactly what I'm saying. And and that's okay, except for actually moving beyond the realm of science. I think that's one of the reasons why a lot of people are angry at each other.
Yes.
Is because there is a failure to acknowledge the great uncertainties we have in life and how we just can't be sure of anything. And I have to say, I probably sometimes, I can't say I'm without anger in my current life, but I feel like I'm a little more mellow. But I would say that I came to a realization of uncertainty, and also I just was able to be okay with it. I'm okay with it. And I'll say, of course, I'll do my best whenever I have to, but I'm okay with saying I'm really not sure. I'm going to have to do X, but I'm really, really not sure that that's the best decision. And here's another realization I made in adult life is so often you're faced with these decisions that you have to make under incomplete information. Yeah. Let's say you're buying a car.
Yeah.
Okay, and you want to know, is that you only get to buy one, unless you're someone very special.
Right. You're
buying this one car, okay? And maybe you study Consumer Reports or whatever it is, and you make that decision, you commit to that car. And I always had this inkling when I was younger that you'd make decisions like that, fairly big decisions, maybe not life-changing, but then you would make the decision, and then later on you'd figure out it was a right and a wrong decision. What I realize as an adult is it's not just before the decision you don't know. Even afterwards, you rarely know if it was the right decision.
Yes.
Who knows? Was it the right car? Hell, I don't know. There could have been a better one or a faster one or something. You never know.
And sort of it also exposes your inner, I want to say psychology, because if you're the kind of person, and to be honest, I am this kind of person, I'm going to buy that car and I'm going to love it because I love it. Because I committed to it, I'm going to love that car. I'm going to see it in the positive light. But I know people in my life who, especially we're in academic medicine, so we know many who, no matter what happens to them, they can win it all, and they're one more prize, one thing that wasn't given to them. Our profession is full of that sort of personality type.
I agree, I don't want this to become a sort of introverted psychological session, but I have to say I've seen that myself, and part of it is, I think we're trained, especially as an intern, to be very alert to any imperfections and very alert to okay, I've dotted these I's. It's am I missing something?
Yeah.
God forbid I miss something, the patient gets sick before I miss something. So it enforces sort of a perfectionist mindset that I think is good for a lot of things, and I think it's not terrible for an intern to have that mindset.
Yes.
I do think it's not the makings of a happy life.
Yes.
I don't think applying perfectionism in your everyday life is a happy way to do it.
I think that's so well said. I had a really good friend, and he put it to me this way. He and his wife had a kid, and he says, and then a couple months into his having the kid, or maybe a year into it, he tells me this. He says, before my wife and I had a kid, we had a list of grand ambitions. We want the kid to do this and the kid to do that, kid to do this, that, and the other. He says, now a couple years into having the kid, he says, my only endpoint I care about is 5 years survival. He's like, I don't care about anything else. He's like, that's success, right? So it's set reasonable goals.
Yeah, and before anyone who's listening to this who might know me thinks me a colossal hypocrite, having identified these things, it doesn't mean that I'm able to abide by them.
Of course, not immediately.
Completely in my private life. Yeah. But for my kids, I've told them my number one priority is that I die before they do. That's my number one priority.
Yes, there's a lot of truth to that. Yeah, that's the goal. Okay, so we could do this all day, but I want to go back. I want to start. I kind of want to get a sense of the arc of your career. And so I wonder if we might back up a little bit to, I actually don't know where you did your undergraduate. I guess I'm curious, when did you find the spark for science? What made you go to the U of C? Who'd you work with there? And what was your kind of PhD? What was your mindset when you were an MSTP, when you were a physician scientist training?
So I think that I think there's people like this in every career. It honestly never crossed my mind to be anything but a scientist. I mean, from when I was very little. There was a time when I was in high school where I was very serious about the violin. And I went to my violin teacher and I told him that I was like a senior in high school, trying to decide to go the conservatory road or go to college and all that. I remember him pausing for a moment and then saying, "You're good at science, right?"
He's like, "I'd stick to the science."
Yeah. So, and he was, although I still play the violin, love it. He was completely right. I would have been miserable. I was not of the quality of had a happy career. So anyway, I went to Princeton. I was a physics major.
I see.
That was all I wanted to do was physics.
Yes.
But two things happened. One was that I kept my sort of hedged my bets by also completing the pre-med requirements. And it wasn't until I was a sophomore in college. I think things are very different now in high school and college curricula. It wasn't until I was a sophomore in college that I was taught what DNA was. And this was that DNA was this macromolecule that had a code that encoded an RNA that actually made the proteins, and the proteins were the thing that did stuff. I had no idea that until I was like 20 years old. And that was mind-blowing. So that to date myself, that would have been like about 1984, 85. And I think curriculum's changed a lot. Kids would know a lot more about DNA nowadays. But so I kept thinking about it. Then the other thing was Princeton is a great place for physics.
Yes.
But I think it was like too great for me in that most of the role models, most of the exciting things were of these people who were extremely talented, like theoretical physicists. And I felt that I just didn't have it in me to be them. I subsequently, particularly theoretical physics was the only thing that was ever introduced to me in the course. I subsequently realized there's no end of fascinating things one can do with physics, but it steered me away for it as I was leaving it. And I became very interested in medicine and did with Professor Jack Fresco there, did some polynucleotide biochemistry. And then decided I wanted to go I couldn't believe at that point my luck. I didn't come from a wealthy family, middle-class family, and I didn't know how I'd pay for medical school if I wanted to go there. And there was this thing called the Medical Scientist Training Program, which we can talk about.
Yeah.
I decided to do, and the key was it paid for my tuition.
Sure.
Both for a graduate part of it and the medical part of it. And it was a godsend to me. And I applied to a bunch of places, and I ended up at U of C because that was the best place I got into.
Sure.
And had a great time there.
Yeah, and I guess I have talked about this training program. I mean, I guess I would say maybe we should talk about it a little bit. I guess I would say I believe that physician scientists do play a super important role. You need somebody with that clinical background. They don't need to be everybody, but there definitely needs to be some people who have both some experience in the clinic and also decide to run a research laboratory as you do. I think you can often think about things from a different vantage, maybe more translational. You think about the unique sort of circumstances. And I guess I would say my only thought about that program is, if you had, I don't know, $500,000, you can spend it in different ways. So one way to spend it is to spend it on training people to do MD, PhD. The other way to spend it is to spend it on the back end and somebody's in fellowship, but they're MD only, but then to do postdoctoral training and stuff like that on the back end. And I think it's an empirical question, which is the best way, dollar for dollar, to get the most physician scientists. One of my worries about the MSTP program, which doesn't fit you, but might fit some others, is I just know so many people who did it. And they did it in part because they were always the smartest kid in school. And the teacher said, you're smart, you got to apply to this and just do both. But they didn't really have that love of research, and they ended up in sort of private practice dermatology or ophthalmology, and it became a springboard for, one of those specialties. I don't know. How do you think about it? I mean, obviously it played an important role in your life. But you must know many people who graduated with you who aren't in the science business anymore, really.
I do. It might surprise you. I probably agree with you more than you anticipated before you started.
Yeah.
I think there is a role for it. I do think it worked out well for me, and I have close friends who who are also exemplars of this program.
Yes.
That I think the United States is very lucky to have invested the money to have people like Mark Anderson, who's at your institution, and others. But there are people. They're I don't know if they're prospectively free riders, if you will, but there are people like that too.
Yeah.
I do think there's an alternative construct that you suggest that we're close to, but we don't quite have, which is, so my mentor was a man named Stanley Korsmeyer, MD. I work on a floor with Bill Kalin, Nobel laureate, MD, trained by a great physician scientist, Dave Livingston, MD.
All MD onlys.
I'm in a place MD only. These are all people who went to medical school and then acquired the training afterwards. And that worked out. You couldn't do better than these people did. I think we have something today that is a little bit like that called the loan repayment program.
Sure, yes.
The problem is that you don't know that you get that.
Sure.
And there are plenty of people, and I was one of them, who was wondering, how the hell am I going to play for medical school? I think there would be a role for a program where medical school, you don't get the PhD, but you commit to a research career that would be attractive to a lot of people. And it doesn't exist. I think there'd be a way to craft it, and there might even be a way to incentivize it so that people really did have to commit to that research career at the end, or there'd be money owing or something like that. It doesn't quite work that way. The full PhD, it worked out well for me. I don't think I would have gotten into Stan's lab. I had a great PhD advisor, Elaine Fuchs. We did sort of something very close to dermatology, and I left dermatology behind, went into cancer when I went to Stan's lab. But I think Stan might have not have been interested in me as a postdoctoral fellow if I hadn't had credentials from a very good lab beforehand. So that helped me as a PhD. But who really knows? You don't really know about your history. This is one of these decisions you never know if it's the right one. I can tell you that I have a daughter who recently was going through the same questions, and I did not push her one way or the other.
Yeah.
She's now very happily ensconced as an MSTP at Case, but and I'm happy for her, but I didn't have it in me to tell her, you got to go this way, you got to go another. I'm very proud of her and glad she did that, but there's more than one ways to skin this cat.
Yeah, I think you're right that there are different ways to do it, and there's so many sort of just seminal scientists who learned it, on the back end, and largely just through doing. It is an apprenticeship to some degree, right. And I think there has to be different paths, and we have to think about the incentives. And you know what? I guess probably like anything, the incentives will always be gamed a little bit, and so you can try to just do the best you can.
Right.
I wonder about, so then you went to the Brigham, and you probably were a very busy resident, but then you stayed on to the Farber. You probably overlapped a little bit with my old boss, Brian Drucker, and maybe Mukherjee was on your heels. He probably was a few years behind you. I mean, you probably overlapped with a bunch of people at Dana Farber.
Sort of with respect to Brian, he left. I never got to know him at all. In fact, I'd never really had much a conversation with Brian. We sort of have a lot of overlapping interests, but never, been together. He was just leaving, and I knew his name only. He wasn't famous when he left the Farber.
In fact, the opposite. The opposite.
And then Sid Mukherjee, I knew slightly, but one of the amazing things about joining the faculty, I thought, was how rapidly I lost touch with the fellows in the fellowship program. Because you get involved in your lab, and that's your life and your family, and you lose touch with the fellows pretty rapidly. So I was kind of, as you say, in between those two, but never really got to know them well.
I see. Who was in your cohort then? your fellowship cohort?
Let me see. Passiana.
Oh, yes. Oh, Passiana was your cohort, huh? And who else?
Yeah. John Stamatoinopoulos, now University of Washington, runs ENCODE.
Yeah.
Joaquin Wong, who's at NYU. Matt Friedman, who's at Dana Farber. I'm missing like 10 of them. Let me see. Eureka Saito, who's at Recon, who is now we're collaborators. We reconnected recently on the way to Japan, and she's now and then Ann Partridge, who's a breast oncologist at Dana Farber Cancer Center.
Yeah. It's interesting. I mean, I think at some point along the way, it went from everyone trained at the NCI to everyone trained at the Farber, sort of thing. It really did kind of the North Pole of the world shifted a little bit. At least in our business.
We do put out like 14 fellows a year, so it's also the matter
the numbers game.
Number,
Yeah. So when you were doing your fellowship training, you also knew you were going to someday be an independent laboratory scientist. I wonder if you might talk a little bit about the transition from going to be a fellow to being on the faculty at Dana Farber. My understanding is that, especially in the years that you were there and you were making that switch, they didn't keep everybody. I mean, they're very selective about who they would give a lab to back in those days.
I'd say and still. I mean, when you're graduating 14 people, you don't have 14 labs that are open each year. For me, maybe I'm just a chronically mixed up person, but as I was leaving my fellowship, I explored private practice opportunities, I explored industry opportunities, and I explored academic positions. And I was literally, things worked out fine for me at the Farber, but I wondered exactly how sought after I was internally, because I only became aware I was about to accept a different position. I was literally walking by a bulletin board at Dana Farber where I saw that they had a posting for a lymphoma starting laboratory position. And so I applied for it and ended up securing the position. But it always struck me, and I asked about this before I accepted, is there any reason why no one brought this to my attention? And I have to say, I always wonder about that.
Yeah.
The sort of thing that naturally someone would have said, but it didn't happen. It made me sort of wonder.
Oh, wow. So, so you for a while thought about, but your clinical practice now is leukemia when you attend.
Yeah, what little clinical practice I have is inpatient leukemia. Inpatient
leukemia service, not allo service, but leukemia.
No, it's very separate at Dana Farber.
I see. So you're getting new AMLs, APLs, ALL2 on your service?
Yeah, and in fact, the service I take care of also has complications of people who have lymphoma, often like febrile neutropenia lymphoma, or people being induced for, some very acute lymphoma situation, so FNN's complications like that.
I see. But if they're getting beam auto or that sort of stuff, they they go to leukemia
service kind of puts them in a remission and consolidates them, and then as soon as they start conditioning,
they go
that goes to the transplant service.
Sure. We had been a place with similar sort of separations, and so these days you do. Inpatient is your service contribution when you do serve. In the past, did you used to run your own clinic for a while?
Yeah, that would have taken me back about 15 years ago or so. I had pretty undifferentiated heme malignancy clinic where I just saw lymphoma patients, and I did that for a little bit, and then laboratory took over. I found that more and more I was out of town, and it wasn't fair to the. Yeah, I had to decide. There's too much of my personality tied up in being a doc. I couldn't totally give it up, but I didn't feel like I was, like I told you, surrounded by great docs. I didn't feel like I wanted to be a second best doc for any patient.
Right. Don't want to be a hobbyist. And I think I think that's right, that there's a point where you can't be gone all that much, traveling conferences, things like that.
I think it works for inpatient medicine far better.
Yes, of course,
because you're not establishing a longitudinal relationship.
Yeah. So why don't we talk a little bit about, I think one of the themes I want to talk to you about, the laboratory themes, is genomics and biology. And I guess, I think, I don't know, maybe you won't like this metaphor, but, of course there's Plato's allegory of the cave where the prisoner is, sort of tied in the cave and sees the shadows on the cave, and his whole life he's grown up seeing the shadows. So imagine the person's reaction when they finally pulled away and see what are the things that make the shadows. They're three-dimensional complex objects. Similarly, sometimes I think about the way in which we think of the cancer cell biology is, we've smashed the cell, we've broken the cell, we've breaked apart the cell, we know the sequence of the genome, and we think, oh, that's all there is to know. And we forget that what's really going on in a cell is a three-dimensional thing. The genome is looping on itself. There's all these factors, proteins, chemical reactions happening at that cell. It's such a complex three-dimensional cellular thing. Nobody really, our understanding of how the cell works is better than it was 100 years ago, but 100 years from now, they're going to look back and laugh at us, just like we laugh at them, And so I think there's this distinction between the things you can annotate and sequence and the real biology. And I feel like that's a theme that's really a part of your work and your thinking.
It is. And boy, oh boy, have you dug up a can of worms that you brought up about 10 different points, each of which I could talk an hour about.
Okay, let's do it.
It's fun. It's really striking because that same Platonic metaphor has occurred to me. Now, I could think, like, there's one disease I work on that where I'll frequently be sitting through talks where people are setting up these complex systems of identifying genes, or maybe now it's like transcript patterns or RNA-seq and all these like very complicated omic-based huge data approaches where they're identifying this, that, and the other thing. And what doesn't get identified are the actual targets that have been exploited to make this disease treatment far, far better. It's so funny. Like a disease like CLL, there's a ton of really excellent work on the ontogeny and the growth and the tumorigenesis and all that, and they identify a lot of things. But you know what genomics has never been able to identify for CLL? BCL2, BTK, PI3 kinase,
lineage-dependent targets. Lineage-dependent.
Yes.
Yeah.
So none of these targets bear genetic abnormalities in these diseases, yet drugs directed at those targets have absolutely revolutionized the treatment of CLL. Revolutionizes so much that the excellent clinical trialists like Matt Davids at my place are just now like doing the clinical trials to see how do we properly combine all these things. Because the progress was so rapid, and it's so funny, it had absolutely nothing to do with genomics at all. And yet that's the paradigm of assigning drugs as like if you're a smart person in cancer biology, you got to be assigning drugs via finding a gene. There's something very satisfying about it, and there's something so tidy in terms of a scientific story. And Gleevec is Brian's Gleevec is the perfect story, where you identify a genetic defect, not a mutation, translocation in that case, that directly tells you about a drug that should work. And not only that, when you give it, you totally change people's lives.
Yes.
That is a life-changing. There's no doubt that Gleevec is more than anything was a life-changing identification with CML. And there's been nothing like it, unfortunately, since then. It was a great first thing, except for you do pick the low-hanging fruit first, I guess. And there hasn't been anything that has been quite as dramatic as the effect Gleevec had on that. But getting back to more modern times, I think I first became aware of you, and perhaps you of me, with discussions around the broader uses of genomic medicine. And I think what both of us considered the fairly uncritical embrace of this in the absence of sufficient data to make it the dominant and only paradigm. I think you might come at it from more sort of social economic aspect, and I came from it from like more of a scientific aspect. I was very concerned about the lost scientific opportunities if we spent all our energies and resources on the pure genomics aspect of it. But we both met, I think, with the general skepticism and a desire for more evidence to support this. And I think the position we were in 5-8 years ago, where I first had become seriously aware and critical of this, was we were in more of a position where, we really don't know how this is going to work out. The testing needs to go, but we should really learn and see what the results of this testing are before we make genomics the be-all and end-all of how we assign of how we're going to assign drugs to patients in the future. And I think you and I have discussed some of the hype at cancer centers or drug companies or the NIH and the NCI all put together. It was all like, we're going to sequence your tumor, get you a drug, and it'll be just like Gleevec. And that was what it was 5 years now. But now we're in a situation where, reluctant as a lot of these studies were to be performed, the results are rolling in.
Yes.
And if you consider like brutally harsh outcomes, like you favor, like overall survival, and I say there's a lot to be. I don't quibble with you on that. Boy, or if you even go to softer
like response
outcomes, like response rates, genomic precision medicine as a global application does not do very well.
Yeah.
And just to let everyone in on like what the sort of numbers are, if you're talking about people with sort of solid tumors who don't have another option, who are subjected to genomic precision medicine, the number of people who get assigned to a therapy in that situation, I mean, if you go by the NCI match trial, is far less than 10%.
Yeah.
Okay. Most patients aren't that excited about simply being assigned to an arm.
Right.
They want their tumor to respond, and they want their lives to be prolonged. If you look at that sort of statistic, it is scarily low.
Yeah.
Now, there are individual arms that prosper, and those need to be examined. And there's there are no doubt people with BRAF mutations and melanoma for sure benefit. EGFR mutations and non-small cell lung cancer definitely benefit. And there's another list of people who definitely benefit. I don't mean to quibble with that at all. However, we do need to be rational in our decision making and realize that genomic precision medicine and these large cancer gene panels have, I think, far less benefit than many give them credit for. Then it becomes an economic issue. It sort of becomes, I was reminded of, it's probably an apocryphal story of Groucho Marx talking to someone. Lady Astor seems to be the conventional sort of, where he asked her, Lady Astor, would you sleep with me for $1 million? And she says, well, I guess so. And he goes, well, how about $100? She goes, no, what do you think I am? And he says, well, we've established that. Now we're just haggling over price. I feel like for genomic precision medicine, sort of like that. It's not a matter of there being no benefit. Yes, there is benefit.
Yes, that's a great analogy.
It's not a matter of it having absolute total curative benefit in everyone. It's somewhere in between. And I think that people say we should do this for everyone because it benefits some people. I really am sympathetic to that. But are we going to apply that to everything? I mean, there has to be, I think we all have to consider there's some limit, some lower limit to benefit that we have to expect from an intervention, whether it's therapeutic or diagnostic, that we're projecting, we're going to apply to everyone. There has to be some sort of measure of benefit that we want to achieve before we commit to that. There's real financial and resource costs. There's also opportunity costs to going after drugs or diagnostic processes that indicate drugs that aren't always useful. And I know one of the things you say is, conventional chemo outperforms a lot of these. So I'm just giving the standard care conventional outperforms. These are the studies that I think we have to just critically examine. And there's no doubt places where people can identify where it is beneficial to do these things. But I would say that the studies just haven't been done, and just the uncritical give it to everyone. Yes, some people benefit. And if you want to employ it as a research tool, that makes a lot of sense. But just like giving it to everyone, I think we need to get some estimate of the benefit. One of the things I have, I'm very happy to talk to this, obviously. I think there's other ways to assign drugs in a personalized way to cancer patients. And what I want to know is, for all the genomics purveyors out there, like, I don't want special treatment. I just want the treatment that genomic precision medicine got. I have a good idea and it sounds reasonable. I actually don't have the expectation that the entire community is going to therefore pay to use the assays that I want to use because it's very plausible and I feel it's a great idea. I think there is some level of evidence that needs to be applied.
Yes.
But I do sometimes feel like I'm hurting myself and this sort of small field of functional precision medicine by insisting on more rigor from precision medicine, because the easiest thing in the world would be to just say, no, we should have very low standards of evidence. And if there's a chance it might help someone somewhere at some time, everyone should get it. There has to be some way you make that decision.
I think your analogy was spot on, that there is this, that's exactly what's going on. I mean, when I think about the history of this whole field, it's really remarkable that the first genome-targeted drug was the best genome-targeted drug, both by the fraction of people who have response. I don't think we've ever seen it as high as sort of a 98% CR rate in phase 1, and the durability of the response, also the most durable of all the drugging, was BCR-ABL. If we had just flipped it, if the first targeted drug was BRAF melanoma, I mean, it's still an effective drug. 60% response rate, but median survival 11 months. I think we would have said, yeah, that's a step forward, but our expectations would have been tempered a little bit. We would have been like, yeah, let's put some more money into targeted drugs, but let's not put all the money into targeted drugs. But because the first was Gleevec, I remember, I watched Charlie Rose. You should watch this. It was like 1999 or 2001, and it was Varmus, DeVita, Brian, and some big shot who used to work at NCI who used to work at Dana Farber, went to work at Merck or GSK. I forget. Oh, I'm blanking on his name. And they're on Charlie Rose and as a round table, and their optimism was just so unyielding that it was just a matter of time that, like dominoes, all the tumors would fall, colon and breast and prostate and lung. They're about to topple. You want to say something?
No, I'm just saying yes, and it's too bad. It's too bad. I think it's too bad. And I think that's, if I can, I mean, retrospectively, this is very cheap to say, but like that's where a skeptical viewpoint can sometimes, be beneficial. Maybe it doesn't make you the happiest person in the world, but you might avoid disappointments like that.
Yeah, and I think that go ahead. No,
I was just going to say analogy. Yeah. This comes from just like a college roommate of mine who is a photographer, not an artist, but he says, like, ever notice it when you get a bunch of grapes, okay? The way it always works out is you just consciously or unconsciously eat all the good ones first, and then you get to the end, the last grapes you're eating are actually not very tasty. And I think I think there's something about that. Yeah. That's why the big and the best stories are kind of first when you're trying a new paradigm.
I think there's a lot of truth to that. I mean, I guess I would say that I don't think, both you and I would encourage them to keep doing this genome research, keep finding druggable targets. Just in the last year, we found some good ones. Trek fusion. Is that a good one equally distributed in all tumors? No, it's in salivary gland sarcoma, infantile dermatofibroma, and soft tissue sarcoma. I've yet to meet anyone with lung cancer driven by Trek, and I heard that some very senior people at big places have yet to see one of those. But, we're still chipping away, but we're chipping away really small. In my mind, I think the real problem has been if you're a funder, if you're in the space of funding cancer research, every time you see a spark, you take everything over there to that spark. We're going to just put all our resources into this spark. Yeah. And what happens is, I was talking to Jim Allison once at an airport. We were stranded, and I had talked to him for a long time. And he talked about what it was like to do his work 2003 to 2007. Almost no funding, laughed at, and then, of course, checkpoint inhibition, whether if you compare them to genome-targeted therapies, I've done this, I mean, I think it's at least twice, probably 3 times as many people, cancer patients, are eligible for those drugs just because they have fewer inclusion criteria. You don't have to have that druggable alteration. I think it's the way we move the funding. So, so the moment we had the TKIs, the cytotoxic world was dead. I mean, nobody cared how taxanes really work. We still don't know how half of these drugs work, these old drugs. We can talk about that.
Amen. Oh God, could we? I think this I think is actually, let's try this out. Let's try to work through this. So this I actually think is a good model that represents very much how scientific thinking goes, probably in a lot of fields, but of course you and I probably know cancer biology best. So the thing we all want to do is cure cancer. Okay. I think that's what we want to do. Now, the thing is, we actually can cure some cancers, okay? And almost always, the drugs that are involved are an anthracycline,
yes,
plus some DNA damaging agents, yes. And if you're lucky, something specific. Like in the case of lymphoid diseases, it's always going to be a corticosteroid. You got to keep a corticosteroid, okay? So, if you would think in a totally rational world, if you explain it to people, it's just like, holy crap! I didn't know this. You have a way to cure people? What we got to do is drop freaking everything and figure out exactly how that works.
Yes.
Because that's where the money is,
yes,
man.
Yes.
We have a way to cure people.
Yeah.
Let's just do that to everyone. But we got to figure out what we're doing there before we do that. And what that would mean is that there would be, until it was understood,
yes.
an ongoing, never-ending fascination
yes.
with cytotoxics
yes.
until we figured out exactly their therapeutic index, their mechanism of operation,
yes.
and how people became resistant to them at every step of the way.
How does CHOP and BEP work in testicle? How do they work? How are they curing this cancer? We need to know that, and then we can extrapolate to other tumors. Go on.
Exactly.
Yeah.
And let me tell you, as someone who's, I think I understand a little bit now more, because I've made this a goal because I thought it was so important. I think I understand the therapeutic index of a lot of these that has nothing to do with what people conventionally think about cell cycle and so forth. I don't think I understand all of it, but it still is amazing to me that we spend so much information on like understanding tumorigenesis in mouse models or something like that. And it's very hard for me to discern what drugs have depended on the knowledge that we've gained from that. And yet just try and make a career saying, you know what, I'm going to figure out how Cytoxan works in lymphoma. That you're not going to have
You're not going to get any funding. You're not going to get funding. I was talking to Tito, the moment Gleevec hit, everyone, what they want to know about microtubule inhibition, poof, It's gone. They don't care. It was always in the next thing. And similarly, we couldn't give a shit about how checkpoint inhibitors, what checkpoints, who cares? But then we got one flash, and now all we're doing is pairing it with Pembro and Nivo. Just pair it with Pembro and Nivo, whatever it is. We don't need to know how it works.
Yeah, I know. I mean, I think the teasing thing about it's not just response rates in the case of Pembro and Nivo. It's these tantalizing,
durability,
long-term, durable it's very unpredictable. Boy, that's nothing I have any particular expertise or insight on. But boy, that's a tough ethical question. That's a thing that always bothers me, and I hate to be too critical of checkpoint blockade and its broad use because Jesus, you see these people who have we're in absolutely hopeless conditions who actually there are these rare anecdotes and they really do exist to really prolong survival.
No, I totally agree with you. And I think the data that there's a sort of a very durable fraction in melanoma, that data is super strong. Non-small cell lung cancer, we're going to learn a little bit more, but we all have those few patients in our clinic that we certainly feel as if that's the case. These were really tumors that the primary defect was immune surveillance, and that's been unleashed and it works. I think that the other thing you're kind of alluding to, both in the cytotoxic story and checkpoint inhibitors, is sort of a genuine human, in many surveys of people, it is suggested that people are much more willing to try something with the low probability of curing them than they are to try something with a high probability of incrementally advancing their survival. I think that's just a human, that's a very commonality among people. And so so I do like checkpoint inhibitors and use them quite often, of course, where they're approved. But we are kind of drawn to the checkpoint inhibitor tail story. We're drawn to CHOP and BEP for this reason, because there's a fraction, we don't know who, but they are in fact really doing well years later.
Yeah. Right, exactly. That's what people want. That's why I went in oncology. The idea that what does a doctor do? A doctor, you go them with a fatal disease. Ideally, if you want to make it get the most emotional bang out of it, they go to their doctor with a fatal disease. The doctor gives them a medicine, and they don't just sort of like get better and have a chronic disease. No, they're cured.
Yes,
that's
I know.
what everyone's going for. That's what's so appealing about oncology. We don't do it enough. We don't do it for everyone, but we actually cure some people. And that's a very, I came to realize late in the game, that's a very rare event in medicine, that someone comes to you with a problem. The infectious disease guys get to do it too.
Yes, they do.
There's not too many docs who get to cure people of disease.
Yeah. And I think that's so true. And sometimes people tell me that the best cure is prevention. And I say, no, the best cure is cure. The best cure is cure. Prevention is when you have given up. You've abdicated. You say you can't cure. You know you can't cure. The best thing you can do is find it early, cut it out, do that sort of stuff. The moment you get in that mindset, you've abdicated. I mean, and that there's some truth to that in some diseases that we don't have cures. So maybe we have to go there. But philosophically, the best cure is cure. You wait till someone's sick and you give them a pill and it reverses it 100%. That's philosophically a better solution than giving everyone something knowing that only a fraction will get it. But I think the reason it's important even this discussion we're having, it's really important for biologists. So you're always keeping your eye on the prize. And to tie it into one thing you were saying about the match data, which is I don't know the polite way to put it, but it's been disappointing. That's the polite way. A bloodbath is the strong way. I mean, it's been really, really lackluster data. And I guess, I often have people do a hypothetical experiment where, to people who make that argument that you were espousing, which is that any response is good, better than what we would otherwise have. My hypothetical argument is if you take 1,000 people and you do whatever genome sequencing you want to do and you give them whatever off-label drug you want to do, and the ones you can't find a match, you give them platinum and etoposide because you got to give them something and you can't find a match. That's what you do in your arm. And in my arm, I just look at their histology, what they've been treated with, and I make my best guess. And I give them a drug, typically cytotoxic drug, but I do it tomorrow in my arm. I'm just doing it tomorrow because I'm not doing any fancy testing in my arm. What I want to say is I really do believe with the current results from these genome studies that my arm will have a higher overall survival than your arm. You're going to watch people die while you wait for tests in a few. And if you only look at it in a single arm way, you're not paying the penalty for all the harm that's happening on your watch kind of thing. And that's sort of my biology, or that's sort of my scientific approach to it. I don't know either one is true because, nobody has an appetite to do those kinds of studies. Appetite is low.
I think you do need that comparison to understand, but since you have me on,
yes,
I am going to propose that there is an alternative to that answers some of these questions. And it's something so simple that listeners, especially perhaps medical as well as non-medical, but I think will wonder, like, well, of course, why not? So why? So this is something I call functional precision medicine.
Yes. Let's talk about
that. The essence of it is it came to me, I think it sort of like came to me a long time ago, and I don't remember the exact conversation, but I was having a conversation with a non-scientist. I can't remember who it was. And they asked me, it might have been my late mother, but just like, so what do you do in the laboratory? Are you like, do you put like drugs on cells and see if it kills them? And my immediate response was, oh, no. It is far more complicated than that. We have to understand about genes and signaling pathways and so forth. But somehow that sort of stuck with me as if it like, that was not a really adequate response. And I wasn't really pleased with it. And I think it just stuck with me. It was always in the back of my mind as I did the genes and whatnot stuff, thinking like, well, why not? Why not? Why is that such a bad idea? And then I would also say, try to talk to any sort of educated layperson who isn't in cancer biology and try to explain why it's a terrible idea. If you want to know, I'm gesturing with my right hand now, why how this drug in my right hand is going to work on this drug in my left hand, why you don't put them together and see what happens. Why is that a bad idea?
Yes.
And so why is that a bad idea? So people aren't just simply crazy. There is a reason why. And I think it's a combination of things. So people actually were trying these things, so-called ex vivo sensitivity assays.
Yes.
And I'd say they had their first peak, their first wave probably peaked around the 90s. And you know when they fell off the map? Gleevec.
Of course. Okay. It killed it. Yeah, right. All the ships moved a different way. Yeah.
So part of the problem is these assays weren't great.
Yes.
If you look at them, they're not terrible. They're not providing no information, but they didn't perform superbly as binary predictive biomarkers.
Was one of this that ERCC1 and platinum story? What was that one? Some polymorphism that predicted platinum.
Oh, but that's like way even more complex than what I'm talking. I'm talking about you just take you take a tumor. What I'm talking about, you take a tumor out of a patient
and you
forget
see
about any genome information at all. Put it on a plate, throw a drug on it, see what's left after. Now these ex vivo assays often took 21 days.
But let me ask you a dumb question. If you take cells from a lot of people and do it on an assay, isn't it the case that in many people the cells will just die? They're not immortalized. They're not going to make it.
It's even worse than that. Often some cells die and some cells don't. Often the ones that don't are non-malignant fibroblasts. And you end up doing your assay in non-malignant fibroblasts.
Okay.
If there is an intense selective pressure, so there's also selection going on and there's also adaptation going on. So that's the price you pay for a long-term culture. And I think all these were evident in the first round that was done like 20 to 30 years ago is when people were doing this.
Okay.
But it occurred to me some years ago that like it was time for a re-examination. Cell biology is better. We have a lot more tools. More importantly, we have a lot more drugs. Yeah. Back then, it was basically, are you platinum sensitive or not? And there's a limited utility to that. So everything was better about it. And so I started to work in this a little bit. And then I like poked my head up out of the hole and looked. And when I say worked in this, let me make that a little clearer. What I did is I was trying to work on better ways, which I can talk about in more detail if you want, but I don't have to, of like putting drugs on cells, measuring something very rapidly to minimize ex vivo culture, and make sure that the thing that you're measuring correlates with in vivo response. So that's what I call functional precision medicine.
Gotcha.
Then I came to the realization after doing this for a while, I had my own assay, my own strategy, that there were these little pockets around the world of people who were doing the same thing in their own different way.
Yeah.
And it reminded me very much like Walking Dead, where there was an apocalyptic virus that swept through the world, and there were these different pods of survivors who are like variously discovering each other.
Yes, and you have to find each other. Yeah,
exactly. And so I have an internet which the people on Walking Dead didn't anymore.
Yes.
So one of the things I did is, with help from the Forbeck Foundation, organized a meeting of these people from around the world and brought them all into one room And there was incredible excitement. And after that, I founded a society we call the Society of Functional Precision Medicine.
Yes.
That just unites everyone who has an interest in this. Some of it is companies, some of it is other people working in academia, but we're all united around the same ideas, which is like there is tremendous information to be gotten out of directly perturbing the cancer cell you want to kill with the drugs you want to kill it with.
Yes,
and you just got to, there's definitely empiric ways to figure out what's happening. I think one of the lack of attractions to this, why don't more people do this? It's so obvious.
Yeah.
And part of it is that it's pretty dumb, isn't it, what I said? You don't have to be a genius to figure out what I just told you. And I honestly think part of the reason why people go into academic medicine, and I don't say I'm one of these people, okay? I fully admit it. I'll see if you admit it too.
It's to be clever. It's to be more clever than others. Yeah, of course.
Exactly.
I think a lot of people, yeah.
And if you're doing something that is as simple and mindless as a 6-year-old could recommend to you, it's very hard to demonstrate how freaking smart you are if you're just putting drugs on cells. And yet I came to the conclusion that this is probably a method that has the greatest utility to change how we treat cancer patients. And I'm telling you, I sincerely believe that to this day. The data improve with every passing day, but I do believe that we are hitting a roadblock into how much we can get out of what I call initial condition static information. And this is all the omics in the world versus how much we can get by dynamic information. That is to say, when you perturb a cell, you can get so much more information.
Your method has the appeal that you're taking advantage of all the biology, not just the genome, the proteome, the transcriptome, and any other omes, and all the stuff that don't fit neatly into an ome, which is all the chemistry going on in a cell. You got it all, and it sounds simple, but it's exactly as you put it. What somebody outside of it would say, you squirt drugs on cells, see what works, right? And you're trying to do that. But let me ask you, what is the intermediary you're measuring that gives you a clue that the drug would be active in vivo? What is that endpoint?
So I'll tell you what I personally am measuring in my lab, and other people have their own measurements. So the way most drugs kill most cancer cells is via this programmed cell death pathway called apoptosis.
Sure.
Just for people who don't know it, every cell in our body has a suicide pathway called apoptosis built into it, so that when a cell goes bad, it should kill itself by apoptosis.
Sure.
What most cancer drugs do is convince the cancer cell to undergo this suicide pathway.
Sure.
This is regulated by an organelle called the mitochondrion, which we're more familiar with as like the power plant of the cell. But it's also can be thought of as a sac of poison. And when that is permeabilized, when it permeabilizes, it releases this poison and very rapidly, within just a minute, commits the cell to programmed cell death when that happens.
I see.
And what happens with the drugs that we use to kill cancer cells, for instance, a DNA damaging agent damages DNA, which is detected by the cell, which causes a transcriptional change that makes new proteins that eventually signal into this pathway and make contact with this BCL2 family that regulates the popping of the mitochondrion and release of the poisons. And what we measure is it's a net measure of the state of all those BCL2 proteins that are governing the mitochondria. So we can measure is like, we don't need to measure. If you wait for this whole pathway that I described to actually kill a cell after putting drugs on it, it can take days.
I see.
We've made a functional assay that can measure just within hours, not the completion.
No, the first steps of the
initiation,
pathway.
The first steps on this pathway. So that's what our value added is. We can make these assessments within like 24 hours of the tumor coming out of the patient. We can make these assessments about sensitivity to, we can say whether or not this drug or that drug provokes the initiation of this process.
So then let me ask you so I guess then one point is a prerequisite for your analysis is the availability of fresh tissue. So leukemia would be
Absolutely.
good for. Okay. And then the next thing would be, are you able to say something like the fraction of the tumor that it's killing? So like some are 90%, some is 40%, 20%. Is that part of your metric will capture that?
It will. So to the first part, getting fresh tumor is a problem.
Yeah.
I wouldn't say it's a challenge.
It's a challenge.
It really shouldn't be a problem because I'll remind you, like I remind everyone else, all tumor biopsies start out fresh.
They do.
It's us that kill them.
Yeah.
Okay. Yeah. We kill them. We put them in formalin or Zenkers or whatever it is. Okay. Yeah. We don't have to kill them. And when we show that we get superior predictive information out of these functional assays, That'll help immensely. The testing that we do will
Sure.
go much faster because we'll have more samples. But that's up to us to prove right now. That's our biggest hurdle right now. And one of the biggest challenges is that we need viable tissue to do our dynamic testing on. So that's part of it. And then, yes, anyone who works in this field will find out that there is tremendous heterogeneity in the tumor sample, and some tumors will have 100%, some will have less. But that may sound unsatisfying, but we're actually uncovering something that looks much more like biology than genomics does, because there is this heterogeneity there is a dispersion, and it's not genetically driven. Mm-hmm. It's functionally driven. There's a dispersion in almost anything you can measure, any biological readout, any functional readout in a population of cells. There's a dispersion, there's heterogeneity, and we do capture that. This challenge is then, amidst all this, you have to emerge with a single summary statistic that gives you a thumbs up. You're either
Either go,
right,
no
you're
go.
either going to give that drug
or
you're
go.
not.
Yeah, right.
And that's our challenge, and that's what we do, is to convert these complicated, mixes of stuff into a yes or a no, and that's the job of a biomarker maker.
Okay, one more question that makes me think about. So, Charlie Swanton has, nicely done. If you biopsy the kidney and you biopsy the lung met and you biopsy the liver met, and you do sequencing, one may find there are sequential differences, and he can do sort of phylogeny, mathematical reconstruction kind of things. If you took a chunk of the lung, the chunk of the primary, the chunk of this, and you did the functional assay, do you find that the different the different clones are susceptible to the same drug, or occasionally is there sort of intra-person variability in the functional assay as well?
So there is intra-person. I'll count some mice as
okay,
people,
yes.
because we said so. So we studied that less than we would like, but
yes.
where we have studied it, they are different.
I see.
They certainly can be different.
I see.
Also, temporally, things are different.
I see.
One of the things that is completely overlooked, and partly because we haven't published enough on this, but we're revving up now, is that when you treat and then relapse,
yes.
we're always looking at genetic changes, and we don't find as much as we'd like. I'm telling you, what you almost always find in a case of a response and a relapse is a turn down of the apoptotic system, what we call unpriming. They become far less primed for apoptosis across the board, which makes me think, indeed, we are onto what is really a pivotal decision event in response to chemotherapy. But yes, I think the type of geographic heterogeneity that Charlie has very brilliantly showed is certainly reflected at the functional level.
I see.
As well.
It might even be, potentially could be diminuted a bit in the functional level, because sometimes different patterns of mutations actually activate the same pathways, and functionally they might be more commonality than genomically, potentially. Or am I crazy?
Yep. No, you're not crazy.
Okay.
And I can tell you it can also be the other way around.
And the other way around.
This is something I think we have a little more evidence for this. Two genetically identical diseases, one, say, in the bone marrow, the other in the spleen, the other in the circulation, might have different sensitivity patterns because they're being influenced by their environment. Mm-hmm. So another case where genetics doesn't tell you all. What I love is, while we're on the it's always amazing to me how the faith people put into genetics.
Yes, right.
when you can now, genetics are pretty good at telling me from my dog. They're actually pretty good at telling me from you. Mm-hmm, okay, mm-hmm, but that's not the job we're asking them to do. What genetics are not good at? Genetics are not good at discriminating. Let's say, if you were kind enough to donate each of these, your neutrophils from your liver, from your teeth, from your eyeballs.
Yeah.
If you sequenced all of those, they would show up with the exact same genetics. Yeah. And I would argue that there are significant functional differences between your enameloblasts and your hepatocytes.
Yeah.
The fact that we would then believe that genetics is going to give anything like sufficient knowledge, especially if we want to design combination regimens, I do not mean to say it's a useless tool. And it is not a useless tool. It can be very useful in certain instances, but I think the worm has turned since we kind of started this adventure. There hasn't been, I think, public acknowledgement, but if you look at how people are voting with their feet, people, I think, are much more receptive to the idea that there are limited expectations for genomic testing. Maybe we should do more of it, maybe we should do less of it, but whether we do more or less of it, we're going to have limited expectations. And I think that's a more realistic assessment now.
Yeah, I mean, to some degree, it's the classic McNamara fallacy. The things you measure count, and what you count can, and everything you. I butchered it. You know what I mean? That you count the things you measure, and what you measure is what counts.
McNamara stuff. I wasn't sure. It's a concept in my mind that I call the tyranny of the measurable.
Oh, yes.
It's the things that the things that we can measure that are so easy. It's like I would put to you that this is why with some of your pet peeves with medical school curriculum, which I share,
yes,
some of them you know more about than I do. Is because some things are so measurable, some things are so testable.
Yes.
That's why they get taught.
That's why they get taught. Yes, because you can query them. But I guess it's called McNamara because in the Vietnam War, if you look down and at all the things you can measure, like who's got more warplanes and who lost more buildings, and it looks like we're winning the war, and then you go there and you look and you're like, oh shit, we're losing this war, right? So I guess that's why they call it named. It's coined after McNamara. But I think you're right. I sometimes think about all the decisions I make as in my clinics. And then I look at what the board exam is testing, and it's testing things that are testable, that are nice little testable things, some of which are useful, some of which I can look up in a table when I need it. Yeah. No, I think you're onto something. I want to ask you one question about the functional stuff. Many years ago, I read about some scientists, and my knowledge isn't too deep here, but they were doing sort of the chimera work by getting flies, fruit flies perhaps, to grow some cancer in it and screening it ex vivo on like on a model organism or something like that. Any thoughts about? I mean, requires a lot of perturbations of the tumor to get it to that point, I would imagine. Are you aware of this, and any thoughts on this kind of strategy?
The fruit fly model, no.
Okay.
I'd say the smallest thing I'm aware of, there are some like xenograft growths in zebrafish that are attractive. Zebrafish are a vertebrate, as you know, that is small and tractable, and you can grow a lot of them very quickly. And then another vertebrate people use for this type of work too is the PDX mouse.
Okay.
These may have promise. I would just put to you that like the amount of work it requires and the scalability, certainly of the mouse models, is this far less than being able to just immediately test tissue, which is what my goal is. The output may be good quality data, but it may just take too long, and it's also far more expensive to be doing work in vertebrate animals rather than in culture systems.
Now, I wanted to shift gears a little bit and get your thoughts on the role of, I think, biotechnology, spin-off companies, and the like. And I'll tell you why I think about it. I recently read a book, The History of Genentech. And this goes back to Swanson and Boyer, UCSF in the 1970s. And I learned a lot of super interesting things. I mean, it was really a very fascinating book, a fascinating history. I guess one of the things I learned was, in the 1970s, the links between physician scientists and the industry were really kind of looked down upon by lots of colleagues. I mean, it was something that I think Boyer personally felt a lot of stigma. And he, in many ways, tried to distance himself from Genentech work. He asked his name wasn't put on manuscripts, things like that. Then, of course, the success of Genentech, I mean, just explosive success, and he became overnight multi-millionaire, probably in today's dollars billionaire. And that sort of really changed the minds of a lot of his colleagues, including, some Nobel laureates who had been very resistant. And now maybe the pendulum has swung a bit on this spectrum, particularly at a place like you are at the Harvard hospitals and in Cambridge and at MIT, where enthusiasm for spinning out companies is high. And I guess I'm really curious because you're somebody who I think has probably thought about both sides of this. On the one hand, I see tremendous upside from it where, technology is only useful if you can get it done, and you can get it done in your lifetime and your career. And sometimes, that's very difficult in traditional processes. On the other point, you talked a lot about how you got to remain objective and skeptical and prove things as a scientist. And the moment you sort of spin it, you also wear the hat of an investor, someone, so many people have made a lot of money by selling their company to another company only to have the other company realize it doesn't work. So how do you think about this role of doctor, scientist / inventor, entrepreneur?
I think the way I come at it is I want to do what I do. It sounds like my medical school application personal statement, but like I want to do it. I just don't see I actually don't think cancer is by itself fascinating enough biology that I would want to study it for its own sake. Mm-hmm. I think developmental biology, neurobiology, I could list many, evolutionary biology, all far more fascinating from basic perspective.
Interesting. Okay.
So I do cancer biology not because it's fascinating. It's a broken system. It's not that interesting by itself. But I do it because I want to find treatments that help people more. And in this world that you and I live in right now, the way to do that is to work with companies that are eventually going to make a drug that's going to go into a patient. And if you don't want to do that, I mean, there's all different levels. There's ways you can contribute without doing that. But if you want to help make better treatments, it's going to involve some level of engagement with a company that makes a drug, I think. So I have no problem with that. The other thing I would say is, and this wasn't contained in your statement, I mean to imply it was, but when I started at Harvard as a faculty member, part of it I think was because I was a junior faculty member and it's easier to apply rules with great rigor to the junior faculty than to the senior faculty. But at that time, the rules at Harvard Medical School were definitely such that really discouraged this, and I definitely got the feeling that it was still looked down upon. We're talking about the early 2000s, early part of the 2000s, and it has changed, so it's easier. People are just more realistic about it. I think that it's important also to acknowledge. I think there was this idea that academics are working from pure motives, and biotech are working purely from motives of profit. And I just want to say, or pharma are working from. I just want to say that I have worked with people in biotech and pharma, and many of these people are people of the highest integrity.
Sure.
These are people who would never permit in themselves or in their laboratories the sloppiness that you can read every day in PubPeer.
Yes, right.
These are people who would never permit, because they can't, companies, by the way, can't tolerate inaccurate or misleading or exaggerated results.
Yes.
They, if anything, need to know the truth more than academics do. Academics, you and I think, have talked about consequences. Academics suffer surprisingly little consequences for being totally wrong about things. Companies go out of business. People lose their livelihoods if you're wrong in business. So probably both for practical reasons, but also they're just simply not bad people. The people I've interacted with in industry, I'm proud to call them colleagues, and they generally are people who are very smart and of great integrity, who have chosen, even more than I have, to just they're all into this idea that we got to make better drugs, and I'm actually, and they're, by God, going to go to a drug company and they're going to go do it. So I do not in any way see some sort of decrement in integrity going from academia to industry. Now, of course, there's like the Scraleys and so forth in the world who give pharma a bad name, but this is not who you're interacting with when you're doing biotech, investigational early science. And of course, there's going to be times where the profit motive interferes with what you see as the perfect clinical experiment. It's not a perfect world. That's the way it goes. But I would like to overcome this idea that people who've never interacted with biotech or pharma, that sort of like it's a bunch of money-grubbing people. Oh, no. I really do not believe that. It's filled with people who want to make better drugs. Yeah, no, I agree with that. And in fact, I always say that when I give lectures on these topics on health policy, it's my favorite audience because they ask the best questions and they're the most invested in these topics. But I think, you've lived through it then. I mean, though, the pendulum swung in terms of academic attitudes towards collaboration with the industry have moved dramatically during your career. That's quite interesting to me. I wonder if you might tell us a little bit about and maybe here I have to eat my fair share of crow because I was a naysayer. But and you know what I'm talking about, the story of venetoclax in AML. And I guess maybe I have to eat my crow, but I guess I'd say I'm happy to eat it because I've looked. You have your phase 3 study. You have an overall survival advantage. I haven't done a super deep dive on it, and I promised you I will. I'm still going to do it. I've been waylaid because, as you know, presidents are coming down with COVID, and there's so many other things in the news, so I have been waylaid a little bit. But I wonder if you might tell me, everyone tells me that you and your laboratory did a lot of the really instrumental basic science,
in elucidating the role of venetoclax in AML and in AML and its potential interaction with the hypomethylating agents like AZA and decitabine. So I wonder if you might tell me, I don't know, how you got interested. I mean, of course, I guess it's apoptosis, so that's how it crossed your plate. And how you got interested in what was the work you did and how you knew that there's something going on here.
So I just want to say, in some way, this is like the realization of a dream of mine. When I was an intern at Brigham Women's Hospital, I was fascinated by the treatment of AML patients. And it literally occurred to me how gratified I would be someday if I knew that I could impact the treatment of these very patients. The sort of, my lab, this BH3 profiling examination of mitochondria that we do, has the ability, this was a question I had a long time ago, BCL2 is an anti-death, anti-apoptotic protein that in some keeps cells alive. It was identified because it was at a translocation of a chromosome in follicular lymphoma. Follicular lymphoma doesn't appear again in this whole story, as it turns out, ironically.
Because it actually doesn't respond well to BCL2 inhibition, right? Ironically.
Yeah, I mean, better than like lung cancer, but not as good as you would have expected when it is the hallmark genetic abnormality for lymphoma.
Right.
And which actually dates all the way back to Janet Rowley at where?
At University of Chicago. Yeah, University of Chicago.
Exactly.
Yeah.
So she identified that, and then subsequently people cloned it, cloned BCL2, and then led largely by Stan Korsmeyer, my late former mentor, discovered like how BCL2 works. So people came with BCL2 inhibitors. When I was asking the question, okay, if we're going to make BCL2 inhibitors, we got to figure out, is it going to work in some cells and not others? And is there a reason to believe it's going to kill cancer cells and not other cells? Because if there's no therapeutic index, what are we even talking about?
Right.
So that was a real focus of my work in Stan's lab, and I developed this method, BH3 profiling, a way of even before the word BCL2 inhibitor drugs, it was a way of discovering whether the mitochondria in a cell were BCL2 dependent. And if the mitochondria were BCL2 dependent, the cell was.
I see. Okay.
So this was a big focus of my work. And it was a graduate student in my laboratory who used this method to identify that AML, acute myelogenous leukemia, was largely BCL2 dependent.
Interesting.
Now, this was heresy because there is no translocation in AML.
Of course.
It's additionally heresy because BCL2 has a cousin called myeloid cell leukemia 1, MCL1.
Okay.
That's another anti-apoptotic protein that has a lot of the same functions.
Yes.
But it has the letter M at the beginning, not B, which BCL2 is B cell lymphoma 2.
Yeah.
MCL is myeloid cell leukemia 1. So of course, God named those proteins, right? It wasn't
right.
So that like MCL1 must work in acute myeloid leukemia and BCL2 must work in B cell lymphoma. So it was heresy to even suggest this. But
fascinating. Oh, you're kind of being the constraint of language is shaping people's minds. Yeah.
Absolutely did. Even like after the clinical trials were turning positive, I remember a review from Lancet Oncology where one of the reviewers was saying like, well, nice, but this can't be so because everyone knows AML is an MCL1 dependent disease.
Oh, interesting. And just to confirm the final point, venetoclax does not directly bind MCL1. It only binds BCL2.
No, only BCL2.
Okay, gotcha. Right. So I see what you're saying. Right. Human beings artificially put these labels on a long time ago, and we've locked our minds into that these must be right. I gotcha.
Right. Exactly. So anyway, Trang Vo showed that using these mitochondrial methods, that a lot of AML was BCL2 dependent. And I don't want to go any further without saying this. It was at this point that I became aware of the work of Marina Konopleva at MD Anderson.
Right. Okay.
And the work that I did on BCL2 and AML was basically from this part forward was a partnership with Marina, and we collaborate to this day. I just don't want to leave her out of the picture. She was a major contributor too. And I actually think it was lovely. We never met. We ran to each other at a meeting. We immediately recognized each other, and we said, do you want to work separately? Do you want to work together on this? And we're like, together, man. And it was work from my lab using these assays that she performed. Also, Leah Hogdal, who actually works for AbbVie now, she provided some very early key information, as well as Aaron Pan, who used to work for Marina and now works for me, all provided very important knowledge. But what we did is we combined our information, and I actually physically went to AbbVie, and they gave me half a day to convince them to start a myeloid program, and the data, all functional, non-genetic, was sufficient to convince them to start a myeloid program. So Marina and I did a single agent trial, and there was a signal not a brilliant signal, but there are actually people taking a pill a day who are getting complete remissions.
I see. So there was a single agent activity response rate to it.
There was. And for like a pill taken at home, put someone in a CR with AML.
With AML, right? With AML, real cancer, yeah.
Right, and then because then the subsequent trial, combination with hypomethylating agents, those originated. A lot of the work originating that took place at MD Anderson. It wasn't me, but the rest, as they say, is history. Basically what we learned from venetoclax from CLL is if you have single agent activity, combine it with stuff that already works in the disease, and it's going to work a lot better. And that's exactly what we found in CLL. That's what we found in AML. So now we have an AML. If everyone knows who's worked in oncology, the sort of the big emotional soap opera of this 7-3 induction where people are admitted to the hospital for 30 days and some of them are killed because of the toxicity. We're at the point now with the advent of oral hypomethylating agents where it may be possible that we will be inducing complete remissions in AML.
With an all-oral regimen.
Exactly. Yeah. Can you believe it?
Yeah, that's and you know what? 7+3 has had a long reign as king. Long reign for many years. Okay,
and it still is for the younger patients. I don't want, of course, for younger patients.
Yeah. I mean, you haven't displaced it entirely yet. We'll see. But I got a few questions for you. Okay, so do you think AbbVie was more inclined to see the value of your functional work for the simple reason that both in CLL, the thing that they're making money from the drug, they don't have a genetic mutation they're targeting. They're doing it functionally.
Exactly. We had preceded our work in AML with a very similar functional work in CLL.
Yeah.
And it indicated CLL is a great target, and it turned out we were right.
Okay.
And I think
that helps your cause.
Well, I think pharma, like we were saying, they have to focus much more on not what should be right, but what is right.
Oh, that's a line from my book. Yeah, not exactly as you say, but I think that's a key point, which is that the real question is what actually does work and not what ought to or it should work, or it's really what works. Okay, let me ask you this. BCL2 is, now you got two under your belt of malignancies where it is playing an instrumental role, but BCL2, of course, I guess maybe you don't want to say, but maybe there are other tumor types that you're zoning in on. You're thinking maybe. I mean, one can. Yeah. Okay.
I mean, these aren't all. There's public information and I'm not involved. There's like 100 trials worldwide, but I would say that like mantle cell lymphoma, there's definitely a signal.
Okay.
Look at the unbelievable work coming out of a collaboration between Dan D'Angelo and Marina, actually at MD Anderson on ALL. So not everyone, but the majority of patients, these are elderly patients who can't endure the big toxic ALL regimen, getting a mini hyper CVD regimen with venetoclax are undergoing MRD negative complete remissions.
I see.
Okay, so ALL is definitely going to be another
place you see it.
It's going to be another big target for venetoclax.
How come when I've given, I don't have tons of experience with AML, but I have some experience with AML giving both, or presiding over it. Hematopoietic toxicity is I've run into a few times. I think some providers say, is there a biological reason why hematopoietic toxicity is enhanced here?
Do you mean for the venetoclax HMA?
Yeah, exactly, for the combo.
Yeah, venetoclax azacitidine and venetoclax azacitidine. Yeah, I mean that myeloblasts are more BCL2 dependent than HSCs are.
I see.
Doesn't mean that HSCs are completely indifferent. I see. When you start adding another apoptotic stressor to it, it increases the apoptotic priming, making them even more sensitive. But I have to say, this has altered my thinking. I think in some cases, AML, I don't know if this sounds foolhardy, but maybe there will be a time when we lean into that. Jacqueline Garcia at our institute is already exploring the use of BCL2 in conditioning regimens. I think that we've, for a long time, held on to this idea of these very toxic induction regimens. Then we just got to let the patient recover for a while, then move them to transplant, maybe give them some chemistry in the meantime. Yeah. Maybe we can lean into the profound I think if we push the doses with venetoclax and HMA, we probably could get even profound myelosuppression.
Okay.
But if we're sending a patient to allo, maybe that's not so bad. Maybe we're getting some conditioning at the same time. And if we had someone ready with an allograft, maybe we could move that in. I think it'll also cause a reexamination of something we don't really do in AML, but a reexamination of maintenance therapy.
Okay. Yeah. because it's all oral now. It's much more convenient.
Yeah.
Okay, that's interesting. And I guess one last question here is, are there any cytogenetic abnormalities in AML that interact in this BCL2 pathway such that it won't work or it will work in this? I haven't read too much about that.
Well, I wouldn't say cytogenetic abnormalities. I would say that, like we found in CLL, people with P53 mutations do worse.
Okay. Yes.
But they do less worse than if you compare them to typical cytotoxic regimens. So like the CR/CRI rate in all comers, elderly, treatment naive, would be something on the order of 70%.
Okay.
If you have a P53 mutation, the CR/CRI rate is like 50%.
Okay.
That's still not too shabby for a P53 mutant AML.
Okay, then this is a question that I don't know if you want to answer, but I want to ask you. When drugs and regimens are developed broadly, often when credit is assigned, it is assigned often heavily to clinical trialists whose name may appear on clinical trials, but often the underlying translational science or basic science was done by someone else. Of course, there are plenty of people who know who were the basic scientists and who are the translational scientists, but sometimes the popular acclaim is attributed to the clinical scientist, who still played a role, of course. Does that bother you in any way, shape, or form? Does that ever bother you or you ever think about that?
I mean, it's nothing I'm selfish enough that it's something I would only concern myself with if it affected me. Okay. With regard to this, I feel satisfied with what credit I have gotten for it. I started, I mean, this sounds hokey, but I have to say it's extremely gratifying for me now when I attend on this service. I see patients being treated with a drug that is helping them that I know they wouldn't have gotten, or at least not this soon. They wouldn't be getting it now if it weren't for work that was done in my lab and Marina's lab. And sounds silly, but like, it doesn't matter what anyone else thinks. I know that.
Yes, you know that. Yeah.
And that is that the realization of that is quite to me. It's like it's very important and means a lot to me.
Okay, last question for you. Our time is I know our time is up, and I really appreciate you giving so much of your time for this discussion, which I found super interesting, and so I'm really grateful, and I've been a big fan of your work and thoughtful commentaries over the years. My last question for you is, I wonder if you might comment about what it's... I mean, obviously, there's a reason why you stayed at the Farber all these years. You could have gone to a number of places to work. I've talked to a lot of people who've done a lot of cancer biology lab work, and they always speak sort of in reverence of the Farber. I once met somebody, and he said, the thing about the labs here is that the lights turn off real early, and the thing about the Farber is the lights never turn off because we're working on this all the time. But I think it's obviously exaggeration. But I guess I'm curious, as a faculty member, if you feel as if there are any... unique draws, or is there something about the culture of the Farber working there that's kept you there all these years? Is there something that makes you feel like I never want to move my laboratory? That sort of feeling. Is there anything to that sort of idea?
I hate to undermine any subsequent bargaining position I will try to establish by saying that I would never leave Dana Farber. But I have somewhat voted with my feet for the last 20 years.
Yes.
As a scientist, I mean, being at Dana Farber carries with it not only being close to outstanding people at Dana Farber Cancer Institute. I mean, I'm on the same floor with Bill Kalin, Jim DiCaprio, Andy Lane, people who are very smart, down the hallway from Dave Weinstock, Kathy, all these people who are just great scientists. And I think that you find I've toured around enough that you find great scientists everywhere you go. But the Farber and Harvard Medical School are big places, and there just is a lot of them. Yeah. And there's not any real major gaps. If I want to know something or I want to talk to someone, they're there to talk to me. And Dana Farber is a big enough place that I can talk to the right clinicians, and there'll be people seeing the kind of patients that I need. There are costs to being a big place. I compete for samples with a lot of people who also want this. It's not all rosy. And there's other outstanding places that have this combination of scientists. I don't I do think that the sort of like density of scientific quality, at least this sounds obnoxious coming from me, but you asked, is just very high where I am.
What about
I love the contact with Cambridge.
What about your postdocs, the people you can recruit to work in your lab?
That's very useful too. I talked to colleagues of mine who are at cities that are viewed less desirable.
Yeah.
I'd say most medical scientists want to have trained in Boston at some point in their career. And, it probably starts out a little bit arbitrary, but once a place gets identified as a hub, it's something self-fulfilling about it. It's just like, it's a hub. So, everyone wants to be there. Just like, I don't know, I'm now grasping for ideas like publishing in New York City or movies in LA. Yes. I mean, really, there's no real reason why movies had to gravitate to LA, but they did. And once they do, that's where you got to be for movies.
We'll take it over to Bollywood now, my friend. No, but Tony, it's a real pleasure to talk to you. And I mean, I think, so many really fascinating themes, but the theme of being a real scientist, of thinking maybe differently, thinking about the cell, we got to talk some more in the future about sort of the relationship between evolution and cancer and how that plays a role in our thinking. You and I both see so similarly to sort of the broad use of NGS and maybe even outpacing a little bit what we know about it and then who should pay and those sorts of issues I think are so central. So thank you so much for doing this. It's been a great discussion.
It was a true pleasure. And if I could I would feel so guilty as president if I didn't allow one final plug, and that is, if you're interested in functional precision medicine at all, please visit sfpm.io. That's Society of Functional Precision Medicine.io, and just learn more about us. We have these free seminars. Show up on Wednesday, see what they're like, and join us.
Thank you so much.
All right, thank you, Vinay.
You've been listening to Season 3 of Plenary Session. Plenary Session is produced by Kiana Klossner. Music by Ian Straley and Audrey Tran. The views expressed on Plenary Session are those of whoever said it and no one else. Plenary Session is not medical advice. Follow us on Twitter at plenary_session. Until next time.